enter, and sustainability depends, well, a lot on us, but a lot more on the donor, on the funder. So nevertheless, I think I'll look at our perspective as implementers. And I also wanted to, the title of my talk should be that it is much more than a verification, much more than an evaluation, much more than just a verification. And I think that is where my thoughts on sustainability will also come. And okay, I wanted to also just put it presentation mode and go to the third. So it is much more than just a verification or an assessment. And I think our supporter from the Ministry of Health has done this very well. So just go to the next slide. Okay. Thank you. And this, my title really is, and he said più forte di Ebola, and I really wanted to say molto più di una valutazione, una evaluation. My directors have spent a lot of time talking about LACHO, so I think I'm in a less better position to do so, but yes, we do have the institution, lower level institutions as well, so lower level facilities. It is the only unique setting in Uganda where you have a hospital which also runs 3 lower level facilities, and it is precisely decentralization. Dr. Lucille would see patients, the same people coming over and over with the same problems and the same complaints, but from very far, or missing the appointments. And so she said, why don't we start 3 lower level facilities, 30 to 50 kilometers away from the hospital, in order to serve those people from a nearby location. So we also run training institutions, and we are faculty for Gulu University, which we are very grateful to Luigi for starting to set up. The rest has been said, but for long, LACHO has been known as an important provider of quality healthcare in the region. And we actually get patients coming from South Sudan, as well as the rest of Uganda and Congo, as well as Kenya, because we are not very far from those locations. Of course, we are at the front line with Ebola, cholera, COVID now. We were not a designated treatment center, but we were serving more than the designated nearby facility. So we have been implementing RBF for some time, as our directors have said. This is just LACHO for you today, training institution. This is the hospital, that's the wall from 1959 when we started. This is the pediatrics ward, where a lot of what has been presented here is housed. And this is the university. Again, the project was designed to engage university students, engage healthcare workers in self-assessment, in reviewing what we do, and thereby slowly start the process of improvement. The unique thing with this project was that we had to engage inpatient care. Previous projects had focused on maternal and child health, yes, but the inpatient care was still bad. Actually, I can also say the pediatrician might say it later, but Even now, the neonatal care is still a challenge. I think somebody already mentioned about sepsis. It's still a challenge. So inpatient care needed a particular focus, and this is what this project really focused on. These are my statements on, on the sustainability. This paper, that there is quite a lot of momentum in quality, and they give 4 reasons that why is that so much in Uganda? Why is that move for RBF so much? And they, in this paper, propose that it is externally driven, or it is due to increased expertise at the ministry, which I believe has developed over time, and that's why Mr. Mwaka was engaged when he was still in Naples, and now he moved to the Ministry of Health. RBF unit was started later. Maybe it's because of national ownership. Again, this is important. I know that in other sectors, in the districts, we hear more and more about result-based or performance-based approaches, even funding. And then lastly, maybe it's just part of the health system, the dire need for sustained performance. This is there, and so you really want to improve the quality of particular things, and you also want to improve the access, certainly. So for Lacho and Kalong, I really wanted to start by saying that it is much more than an assessment. It is a lifeline. This is a very important point. So yes, we can do mathematical modeling of what worked, what didn't work, but something already worked. Because there was some funding, this might have separated us from collapse, especially in the midst of COVID. I know that there was a time that Kalongo Hospital had at least 20, 30 staff infected, and they had to be quarantined. I know that we are not supported by the government significantly. So, any funding can either mean we cut down staff, so lack of funding, we cut down staff, or we increase the fees. If we increase the fees, access falls down significantly. So by giving funding and increasing access, we think this brings in sustainability of care, sustainability of the systems of the hospitals, the support that we give. Again, it provided a watchful eye, and I want to argue that this watchful eye is an ingredient for sustainability. So earlier on we talked about this. I think probably what I'm going to talk about are more the first two, the lower ones, the pizza advert, the pizzeria advert. They say, vivi la migliore esperienza del delivery. So there is the lower aspects. We say the activities, the early outputs. This probably from our perspective, and again from the provider's perspective, are the key in ensuring sustainability. What we do will determine if such a process can ultimately lead to an outcome. If such a process can ultimately lead to a product or ultimately in the end an impact. So your notes are seen. They can motivate you, your practice, but it also benefits the patient. There is the self-consciousness. So you know that your form is going to be audited and you're more careful. We think that this ultimately impacts on the health system and they bring the desired benefits of the funding. After all, the access should be improved, the quality should be improved. So RBF as a motivator, I think, has been discussed. Certainly, there are many mechanisms by the different RBFs. The latest called Enabling Health in Acholi is actually imposing that a certain percentage of the amounts gained should be given back to motivate staff. This was not the case with Ikes. But of course, Lacho Hospital, as Dominique tried to really bring it out, we did try to, of course you'll be assessed. So 2 ways. Sometimes the expectation exceeds the performance. So if we are performing in order to get the bonus, as previous speaker has already said, that impacts negatively on sustainability. But if we take the bonus as an appreciation in gratitude, it changes. It changes many, many things. So the bonus and how we deliver it can impact sustainability, because people can also rebel. The other thing is that in Lacho, RBF is an integral part of the quality. So when my director said the quality office, the quality assurance, we integrate these two. We know there is a challenge of bringing quality improvement with quality assurance all in one place, but there is a distance you can go. You can't fragment everything too much. So RBF is in a way still housed closely with quality in our case. In any case, because we'll have to identify the issues and act on them, somebody has to take lead. So we work on emergency readiness, client satisfaction, structures and infrastructures. They were the quickest wins, as you will see. The directors are more willing and listening when there are issues. Supervision, duty schedules. So we think that when these things increase, you can fund us again later, because the structures are there. You trust that the system will deliver. I didn't talk about accounting and financing, because the auditing and other things, they are not measured directly here, but that's another key important determinant. So this is I like this picture. It's the nursing duty schedule. We know that this nurse will do these activities today. It wasn't there, but we check it now, and it's important. We have the work plan for a week or so. You know that this time we do this. This time we do basic small standardizations. I think if you find a place that does such a thing, you're likely to fund it, and you're happier to put your money there. So RBF also helps us to implement standards. It is clear there was resistance. Doctors thought that it is old-fashioned looking at books. They really wanted to write their wonderful diagnosis, long diagnosis and extreme prescription. But slowly they are coming to understand that standard operating procedures are useful. It standardizes care, refer to that guideline. It is important, refer to that, it might save life. And this, I think, slowly have improved. And they can be transmitted to the generations also, because, as I said at the beginning, we are a training institution. And then when standards are followed and perpetuated, access to quality increases. And I think this will enhance and actually put us in a good way of sustainability. So this is oxygen. I must say that delivery of oxygen is not well known by many. How much? How much do you put? How do you deliver it? I know COVID might have helped a bit, but so this is for oxygen, that is for the critically ill child. So you can save a life just by looking, and over time you know what to do. One of the biggest things for me has been student engagement. We engage university students, some of whom have become doctors, some of whom are now going back for specialization. And we think that part of course, there is learning. They're engaged in learning, but we also do what is called percussion. For us, the medical students need to be asked some questions and they defend their decisions. So during the chat reviews, they really enjoy it, because if you're talking about malaria, you want to put yourself in the shoe of this doctor who is making the decision, and you find the basis of this decision and what you would have done and what your differentials are. So it's, on assessment day, that is their word round. Actually, it's a very good round because they can learn. But there is also what they now perpetuate. We think that when they become medical officers, they know that it is important to look at what you do. We sometimes learn on the most senior person's files, and we find mistakes. And the person is open to correction, open to understand that, oh, there was a problem. This mentality is important than the doctor being a demigod. Somebody already talked about the hierarchies, sometimes which are obstructive. So these are students. What I didn't say is that they are also helped. That is a student, that is a nurse. They are putting IV lines, IV cannulas. And you see, together, side by side with the health worker. This is how we mentor and get. We also ask students to put their objectives. You know why you're there. And you know what you're doing. It is much more objective. And we think this has helped. So this is the pediatrician teaching medical students. And again, that is nursing students being taught. This has been a crucial part. This is a chat review. And you gather around the table and anybody reads. If you cannot read somebody's handwritings, usually you don't read your own file, so somebody else can do. So teamwork has been built, and we think that this teamwork is a recipe, is a crucial part. And again, we think that we've broken barriers quite a lot. And I want to say that pediatrics ward has been the leader in this. The children's ward has been the lead because it started the inpatient care. Slowly we have gone to other wards as well. So you see, it's a team. I think you see Dr. Venice, nurses, this is another specialist. So it's a critical management tool. My directors are able to supervise. They know what is happening. The things are reported. Quarterly assessments, but also because of bonus, we have to assess staff and how they are performing. So people are engaged. It is not just a feeling. You know that somebody is doing certain things, you're using certain parameters, but the students do this like you've seen me doing. It's important how we build up teams and breaking barriers, different multi-sectoral. So there are scores. Earlier I said that I know that our scores for RBF will be brought, but we do not only assess pediatrics. The ministry person comes and assesses medicine and assesses surgery and assesses. After pediatrics, we introduced inpatient care assessment to other units also. We went to gynecology. Because we were doing obstetrics more, we went to gynecology, we went to medical ward, and now we are going to surgery wards. It does not have to depend on a payment anymore. The quality team can assess and know the gaps and people intervening. And the team that assesses gives feedback. We have had to modify our meetings due to COVID. Sometimes we had it outside. But we give feedback to the whole hospital, so everybody is interested and they really attend. Yeah, so from the gaps, you take actions. Actions preferred to be taken from the department. So you have to modify what you're doing. So assessments have been looked at more critically than the said indicators. I want to thank the ministry person. When he sees something, he goes beyond and asks why and what is the root cause. And to understand that, they make sense of the observations. Many times it has nothing to do with the indicator. But because you have seen it, you take action. And we think that this more robust than just the indicator. That is why sometimes it's difficult to define human behavior, to say what it is exactly. But when it is changing positively, it is important. Measuring it might be another issue, and modeling it. So there's a tool for learning between the facilities, Kalon, peer assessments. This has not materialized fully, but yes, initially we were supporting chat reviews and other ways in which we can. We think that, as the director said, there are certainly ways in which we can support each other. For example, Tito, the pediatrician, did quite some good work in the neonatal unit of Kalongo. It's a smaller unit, of course, compared to the Lacho one, but standards have been put on walls, and it's something we can learn for. So ultimately, it's also a tool for resource mobilization. My director said that we present RBF, we can present to you the results. We can present it to you at a certain quality. Give us the money, trust us with the money. We think that over time, getting this experience, it's important for us as a means of sustainability. We need the money, and the needs are there. And we can deliver the quality. We think that in a way that can help to sustain the RBF. Thank you very much.
Thank you very much, Dr. Emma. These are the people that are on the front line every day to treat the patients and to provide all the services. I just want to say now we have to go for lunch. The questions, if somebody wants to send them on the chat, they can, and they will be answered in the afternoon. So thank you very much. The contributions have all been very interesting. See you after lunch.
Un'altra cosa, ma sono giù di per il microfono, prova, prova, come si sente? Sente una fa? Però si parla qua, così, non si può mai.
Prima non si sentiva bene.
Prova, prova. Allora, proviamo fisicamente, come se fosse, se rimette a posto qua. Questo come si comanda? Comando all'inizio. Io che devo fare? Come vado avanti? Soltanto qui, sì. E via. Si mette così, si sente.
Here's report,
Allora loro si
report with
penseranno.
financing world. Si sente buono, no? Vai. Il problema è che questo cazzo di schermo copre la faccia, come questo respiratory babies and cross many gaps. Non c'è bisogno. Io mi comando da qui, no? Need to rearrange the suction repaired. Flash will not be mini but large. There is a further need for the scale. Checklist, which is a checklist. Ma non cammina con i singoli, con le animation che ci stanno. Aspetta, fammi vedere la pressa. Sicuramente ci stanno alcune animazioni. The old words, percentage of... Quest'altro affare si deve togliere quel quadro. Sì. Daily morning meeting, quarterly meeting, ecco qua. Però sì, le animazioni fanno schifo, va bene. Longo. Sì. Ok, funziona, diciamo, vabbè, tutto a posto, vabbè. Allora, questo microfono rimane così, no? Vabbè, perfetto.
Prova. Si sente così? Non si sente? Ah, hai capito perché? Perché in pratica quello fa tipo... Si sente però basso così. Così invece si sente alto. O no? Così si sente bene. Guarda, io non l'ho capito. Così è alto. Così è acceso però è basso. Così è acceso, si sente? Non si sente ed è acceso invece. Vado a mettere... Così è acceso... Capi? Che particolare questa cosa. Così è acceso, forte. E per un'altra volta è acceso ma basso.
Prova. Prova.
Prova, sa, sa. Prova, prova, sa, sa, prova.
Yes. You'll be fine. Alex.
Signori, prendete posto, cominciamo subito la sessione pomeridiana. Vi prego. Have a seat. Ok. Sì. It is my pleasure to introduce the two persons which worked most to this RBF project. And they actually will introduce the actualities and the practicalities of these two projects in the RESUL Hospital, Dr. Elisabetta D'Agostino, and the Ambrosoli Hospital, Dr. Livia Colvin. Please, Elisabetta.
I'll leave Livia the word, and then I'll close. I'll follow her.
So, thank you, everybody. I hope that you have enjoyed the pizza, and I hope I will not bore you too much with my after-lunch brief introduction. So, after we have heard a morning about the implementation of the RBF in Uganda, various experiences, comments, and also some insights about implementation in Kalongo and Lacho hospitals, I would like to introduce the study that was carried out by Professor Greco and his team in the University of Naples, in cooperation also with ICE and the Ambrosoli and Corti foundations. So the objective of the RBF project funded by ICE was to increase the quality of care in Lacho and Kalongo hospitals. Now, the objective of the study was to verify if the project has been effective in improving the quality of care. And we wanted to do this using a different methodology from the methodology that is intrinsic in the RBF project, because the RBF is focused on quarterly monitoring of quality. But as our speakers were saying this morning, there can be some critiques. For example, hospital who did the very boring task of scanning 400 clinical forms and selecting them, because due to COVID it was not possible to do this operation in presence. And the results of this study were really astonishing. Professor Greco will go more in depth later in explaining how much the study of the clinical forms has told us about the improvement in the quality of care. For example, in Kalongo we saw a 900% increase in the quality of management of sepsis, which was astonishing for us. We were not expecting such a huge improvement. So it was very interesting to have this study to show us from the clinical forms what really happened in both of these hospitals, comparing part before the RBF and after the implementation of RBF. The study also includes contributions from the Italian Agency for Cooperation and Development, contributions from Thomas Molteni and Elisabetta from Corti Foundation, and an overview of RBF in Uganda, RBF experiences, and also very interesting comments from our colleagues in Uganda who have been implementing the project on the field. So I will leave the floor to my colleague Elisabetta.
Thank you, everyone. As Livia was saying, the main aim of this publication, the Corti Foundation and Ambrosoli Foundation decided to edit and print, was to disseminate the result of the clinical research and the high survey conducted by Professor Greco and the hospital staff, which I really want to thank for the huge effort they did, because part of the study was conducted during the COVID period, so it was not possible working together in presence, but we were forced to work by remote. What I'd like to add is that together with the result of the study, we decided to include an introduction about all the RBF projects that have been implemented in Uganda, in South Africa, and in the two hospitals, to give a wider scenario and also to explain the increasing interest in towards this approach in the country, and to explain in some way the context in which the HICS project has been implemented. Another thing I'm really, which we felt was really important for us, was to collect the opinion, the challenges, and the experience of the main actors implementing the process. the project. What I mean is that beside the qualitative and quantitative data proving the impact, effectiveness of the RBF system, it was of paramount importance for us to verify all the process, what it has meant for the staff implementing it, which challenges they have to face, which result they could achieve, and also which solution and best practices have been found during these processes. And I guess this is really important for us, because what we have seen, and I need to thank all the hospital staff, Dr. Venice, Dr. Emmanuel, Dr. Ocao, and the directors, for the huge effort they did in creating a process that is quarterly facing new challenges and looking for solutions that can be applied also in other worlds. So creating a kind of virtuous process of best practice definition and lesson learning. Before leaving the stage to the colleague, which can explain much better than me how it was for them to implement this kind of approach and the project they managed, I just want to add few information coming from the final evaluation of the AIX project that we conducted as soon as after the study research, and in the framework of which we organized a survey to check in some way to understand which was the impact on the behavioral change of the staff. And I need to say that the first results are really encouraging in the sense that what came out is that after an initial stage of concerns and probably some fear from the staff about the workload that were coming with, it was included in the implementation of the approach, they slowly realized that it could be really effective for the challenges that it was posing them in looking for a better organization in the world, in increased sharing of challenges, problems, and other issues, as well as in the task definition. I think this is in a really great lesson for us, and probably is the good achievement, the result we obtain in this sense are coming from the good management of the ward and all the process in the two hospitals. So I leave my colleague from Calongo and Lachor to better explain how it happens. In this stage, I just want to thank them for the huge work they have done in this regard. And I want to thank also the Italian Agency for Cooperation and the Cariplo Foundation to have given us the chance to test this kind of mixed project in which traditional approach and RBF system are mixed together. And finally, I want to thank Professor Greco and all the staff of the university, Professor Sergio Beraldo, who intensely wanted this Congress, because I really feel today we have the chance to collect feedbacks, ideas, food for thought for future improvement of the system and for future application, both in the two hospitals, but also in other realities that could be interested in it. So thank you very much to all of you for sharing with us your opinion, views, and parties. Thank you.
Thank you, Livia, and thank you, Elisabetta. I want to personally thank you so much for the great effort and work you made during all these years of project. Now it is the time of intervention of Professor Greco. Professor Greco is a professor of, we all know him, of the Faculty of Pediatric at the University of Naples, Federico II, and meanwhile he's setting his presentation. I want also to express our gratitude because he was so close to us during to the hospital first and the foundations during verification process. So thank you, Professor.
We go directly to analyze the data we collected. Actually, as you know, this RBF project started from some gaps. You know, we had problems in the children's ward. You know, very often the children were put together into beds. It was difficult to share oxygen concentrators. There were problems and several gaps for the emergency procedures and equipment to be repaired, and all the system of hygiene have to be revised. So we had gaps we started from. Despite all the efforts, these gaps are always present in our own hospital in Italy as well as more in Uganda, and needs for further equipment. So the checklist was quite simple, and it actually regarded every 3 months the evaluation on the situation of the ward, cleanliness, safety, hygiene, equipment, drugs, laboratory and radiology availability. All these items were scored from 0 to 3 according to an independent evaluation, which was carried by Dr. Mwaka and his team, internally and externally, to assess if they have been reaching or not the target every 3 months. And according to the quality of score, the total quality of score, the sum of scores of all these items, the reward was given to the staff. And so we have hygiene and cleanliness, a special form, which regarded supplies, the sharing of beds, the cover of the beds, the cleanliness of the beds, the cleanliness of the rooms, the management of waste, the availability of water, the situation of latrines and showers, sterilization, all the practical items which make the difference of the quality of care given to patients, actually. And this was a very important point also. Clinical nursing procedures were evaluated according to 10 selected items, disease or procedures, how you treat malaria, dehydration, convulsion, pneumonia, meningitis, sepsis, if the diagnosis was according to a protocol, if the therapy was properly prescribed, if the administration of therapy was properly, if deaths are reviewed every single morning, we have 2 or 3 deaths every morning, if mentorship was available and functional. And then we have a checklist on the emergency readiness. If the cupboard was ready, if the university. Postdocs were occasionally present. So we started from my weekly meeting to discuss general management, and we shared with all the staff, nurses and doctors, we shared all single items, selected the appropriate items, and started the procedure in 2018. And every 3 months it was going on. So we now see the results. Less bed sharing, individual equipment will become ready. We had oxygen installed into the wards, so we don't need anymore to share oxygen concentration, but we have a proper oxygen delivery. Intensive care was also provided better. The safety was completely renewed in order to avoid any accident related to safety. More equipment was available, water was available, and trash bins were appropriately selected according to differentiated management of waste. Instructions for the waste management, emergency, and what is actually results. These are the quarterly assessment score, every single score. You see each line is one of these scores. For example, I will show you the clinical line, the red one, the yellow one. And you see that after the very first quarter, the first 3 months, there was a steep rise. This is a polynomial curve, which means that they change it gradually to a very good level. All as this fitting on the yellow line is the same one can be fitted to the other lines. It's a third-degree polynomial, which means that the changes was gradually and constant all over the time for 3 years. Unfortunately, the training suffered from the erratic presence of medical students and more difficulties with postdoc, but nurses were always present. Emergency did during the time, which means another important thing. There was no sitting down after the first success. After the first year, they reached a good point, but they continued to pursue a good threshold. If you see the yellow line is jumping up and down, because specialist was not always available. They have months with gaps from specialists, no pediatrician. So the assessment of the form revealed that they could not really attend as well as they could with the presence of the specialist. And also their training and emergency was constant in a way. And this was the situation in Calongo, very busy before the project. By the resources of the first year, which were not divided among the staff, they renewed completely the children's ward. So the situation changed dramatically. And this is the percentage of the optimal score which have been gained in La Chor, and you'll see that the steep rise is the first year. This first year, the first block here on the left. And then after that, there was a more or less constant trend towards a very good performance. Training was jumping up and down as expected. That was less easy in Calongo for the reasons I already told you. Less presence of the pediatrician, so a good rise in the first year, the first 3-4 quarters, and then difficult jumping to a good level, to optimal level, I would say, in the at the end of the second and during the third year. And this was reached by sharing, by doing meetings, discussing clinical cases every day, discussing with nurses management of the ward, and really putting an effort for a teamwork. And these were the global overall changes, how the score changed from 2018 to 2020 as percentage of the starting score. And you will see, non c'è una sfaccina di puntatore qua, non posso giocare con questo, sì ci sta. You will see that the blue lines is the one from La Chor, and this pinky sort of thing is Calongo. And you see that La Chor improved very much, 80%, 50%, 60%, but Calongo had to improve much more because they were starting from a very much lower level. Okay. And you will see that emergency in training changed very little, while structure and management, hygiene and clinical scores improved tremendously in both hospitals. What are my preliminary comments? La Chor, the action put in place to improve the structure, the management and the procedure of the children's ward allowed a step rise in the achieved percentage of the maximum score. It should be considered that the starting status of La Chor was already very decent in 2018. So dramatic yellow curve that I showed before. And training suffered from the absence of supervision and the occasional presence of trainees. Now, the clinical management, the overall clinical management, how they take care of the very sick and severe children. The list of diseases are deadly disease. How they really improved. And you will see this is the starting point with distribution is a non-parametric item anyway, before the project, and this is after the project in Calongo. You see the tremendous change, which was objectively measured by assessing each clinical forms. 150 clinical records of 2016 and 150 in 2020, which were faxed and dispatched to Naples from a very committed person, which spent several weeks doing this job. And we did an independent observation. Margherita Cidiago and I reconstructed hundreds and hundreds of clinical records here in Naples and examined them blindly according to international standards. And you will see, that also in Lachaux there was a significant, statistical significant improvement, not as large because they were starting already from a quite good level. Now, when you do an analysis, you have to understand that many items are intercorrelated. So there's no way of observing each single line for each single item. You have to do a multivariate analysis in order to understand what is important. And actually, we were not surprised to find that it's not a matter of equipment, drugs, or let's say facilities. It's a matter of care, of attention to the patient. The most important variables which make the difference before and after the project were presence of symptoms referred in the clinical records accurately. If you actually admit a child, despite you have 20, 30 every morning coming, you have to spend time to collect accurately symptoms. Then to measure the weight of the baby, which is often done by nurses in other forms, in other clinical forms, but you may not use that to manage the baby daily. And doing a proper clinical exam. So this does not require X-ray, does not require labs, does not require big equipment. It requires time, dedication, and care. And these three variables do explain about 70% of the variance of the difference between before and after the project. And reinforce the idea that we do need dedication and practice more than equipment, like already has been said and showed very nicely by this morning. And so this is the Calongo stuff after the project, new equipment. And I just want to say that also a nursing evaluation procedure was included in this project. And you'll see this is a very, very delicate point because each clinical record has the nursing sheet, the daily sheet from the nurse. And they were independently assessed by Valentina Muzzi, which was there, and sent to us. If therapy are given properly, if the chart corresponds to the correct patient, it's not a funny question. It does happen. If weight and vital signs are recorded, fluid balance chart is present, when applicable, bowel action are recorded, all these small things which needs care and time are being evaluated. And a total score was obtained every 3 months again. I don't want to take much time because we were so delayed. I just want to show you the results. This is the average score in Calongo before and after the project. This is the average score in Lachaux before and after the project. As you see, in both hospitals, these nursing quality indicators improved significantly, although not enormously, because also of the shortness of the staff, but had a real incidence in the quality of care. In conclusion, I would say that I've been there now 21 years after my twin brother Donato, which started before me, going up and down to Lachaux and occasionally to Calongo. I was impressed how these people, in a very difficult situation, with hundreds of very sick children, seeing the deaths every single day, a child dying every single day. Here in Naples, we see a child dying every couple of months. Here, every single day. And having a lot of pressure, these people actually accepted the project, dedicated to the project for a very minute reward after that, and changed the situation. and I am sure that they will go on with your support. Thank you.
Thank you, Professor Greco. Now the next intervention is by Michela Collaro. Michela Collaro is a PhD researcher from University Federico II of Naples. Is a member of the research team coordinated by Professor Beraldo of Department of Economic and Statistics.
Thank you very much. It's a pleasure for me to be here today and to talk to you about the results that we have found in an analysis performed with Professor Sergio Beraldo and Professor Domenico Suppa, aimed at assessing the effectiveness of result-based financing. Well, we have seen this morning what are the main issues related to both the design and the ex post evaluation of an RBF project. And that the key point is a clear define of the results, because the results to which payments are linked. At La Chore and Calongo hospitals, payments were linked to both quality and quantity indicator of the healthcare provided. Well, to assess the effectiveness of result-based financing should concern both the impact on final outcomes, such as population health, but also the change that we observe in the result chain during the result-based financing, the period of intervention. And in this work, we have investigated this relationship by means of two approaches. We first have looked at mid-term structural and procedural measures assessed during the quarterly quality verification. And then we have looked at a more objective measure proxying the efficiency of healthcare. And our results relies on two different types of data, where the first are data related to the quarterly evaluation at Children's Ward, and including the score assigned to each item pertaining to the 5 domains of interest that are infrastructure, hygiene, clinical processes, and emergency and students training. Then the second set of data is a collection of clinical records randomly extracted in the period before the RBF project, that is 2016 and 2014, and clinical records of the end of the project in 2020. Now I'll first show you the evidence from the quarterly evaluation at the Children's Ward. This table summarizes the data. We have a time variable identifying the quarter of evaluation. We have the score assigned to each item, and which sum up to the score of each domain. And then we have the amount of money that has been given at the 2 hospitals. The money basic that basically covered the general expensive, and the money bonus that is the extra amount of resources that has been given to the hospitals and that include workers' incentive. Now, what is interesting is to see if the money, the amount of rewards received at time t could affect the improvement in the score in the subsequent quarter. That is by comparing the total score and the money received at the time t-1. In this graph, you can see on the left the total score, the correlation between the total score at time t, and in the graph on the left, the money bonus at time t-1, whereas on the right, you can see the relationship between the total score and the money basic at t1, the money bonus at time t-1. In column 2, we have the money basic at t-1, and in column 3, the total of reward received. And as you can see, the relationship has a positive sign, and it is statistically significant. Now consider that the amount of money is expressed in 1,000 euros, and this coefficient in the first column tells us that if we increase the reward of 1,000 euro, we can obtain an improvement in the total score of 1.75. And the coefficient related to money basic is smaller in size, but it is still statistically significant and suggests a significant relationship also between money basic and the total score. In this other model, instead, we look at the variation observed in the total score at time t, that is the difference between the score obtained in the previous quarter, and this at the time t. And the regressors are the variation in the money, the extra amount of resources that we receive, that the two hospitals received at time t, and the money received in the previous quarter. And we also consider the total score at the time t-1. This model allows to single out the short-term effect of the reward, that is the one given by the variation observed in money, the long-term effect, that is the money received at the time t-1, and as you can see, the coefficient is positive and statistically significant, suggesting that both the extra amount of resources and the one received the quarter before have an effect on the improvement in the score. Then we have a negative relationship between the total score observed at the time t-1 and the variation in the total score at time t. And this negative relationship is due to the fact that there is a maximum score attainable, and so the higher the total score pursued in the quarter before, the smaller is the improvement that we can observe at time t. We then repeat this exercise to the single domains, and we can see again a positive relationship between the money at time t-1 and in the first graph, the structures. In the middle, we have hygiene, and in the third graph, we have the clinical management. Whereas no significant relationship is found if we look at emergency and students training. These are the coefficients, and again, we see that they have the expected sign, and they are statistically significant. I move to the next slide, that is the clinical management. Here we have again a strong relationship between the money bonus and the score obtained in the clinical management. So we have that an increase of 1,000 euro in the reward produces is correlated to an increase in the score of 1.1. Well, then we have performed a non-parametric test to verify if the difference in the period before the intervention of the RBF and the period after is statistically significant. And we have performed this analysis to all the domains of interest. And we found that all the differences are statistically significant. So the score observed in the period before are statistically different in that stay. And the coefficients, as you can see, as the expected negative sign, suggesting that an increase in the amount of resources received is correlated with a reduction in the average days of hospital stay. And this is true for all the coefficients, for the money bonus and also the money basic. Despite it is it is a bit higher in the case of money bonus, suggesting that it is this kind of reward that is correlated with the reduction in the length of stay. Then we have restricted the analysis to the more relevant diagnosis in terms of frequency in the observed period to assess the differences in the period before and after the implementation of RBF. And in this graph, you can see on the left, the values for La Shore, and on the right, we have Calongo, and we have a comparison between the period before and the period after. This data suggests that there is actually a reduction in the variability of the length of stay. It is clear in Calongo, we see that for all these diseases, there is a reduction in the size of the box. Whereas for Calongo, we observe again a reduction for almost all the diagnoses, but for anemia and malaria, we instead observe an increase in the variability. Then we have again performed with the Wilcoxon rank test on this value, and we found that there is a difference in the distribution before and the distribution after in the length of stay for malaria and pneumonia diagnosis. And considering the relevance of this diagnosis in terms of their frequency in this context, this result strongly confirms and assesses a positive relationship between the rewards and improvement of quality in healthcare. And this both if we look at the quarterly evaluation and if we look at the length of stay. However, what is interesting to assess, to evaluate the effectiveness of an RBF project, for example, due to the short assessment period, the items recorded could be collected either monthly or weekly in order to have a size of study that is greater. And then what is more important is to collect data in a control group that does not receive the rewards, because it would allow to apply econometric models in order to express an evaluation on the causality of the RBF project to the improvement. And also collecting data, in other words, in the same hospital would allow to investigate the external positive or negative effect of the incentive scheme. Thank you very much.
Thank you, Michela. The next intervention will be by Professor Domenico Suppa from University of Campania Vanvitelli. Ah, I thought it was intervening by Raymond. Sorry. Okay, so now I call Dr. Venice Omona. He's the pediatrician from La Shore Hospital. We have some problem. Okay. While we try to set up the presentation, I would like to take the opportunity to thank and express our gratitude for all the team and the staff of Kalongo Hospital, Alachor Hospital. We received some photos this morning showing they are attending and participating to this event by remote, so we are very happy. It's a sign to be closed even in this occasion. So here we are.
Yes, good afternoon, everyone. I hope you can hear me clearly. I'm Dr. Venice Omona. I head the pediatrics ward of Alachor Hospital. And I know since morning we have been talking about children's ward, and the pediatrics department encompasses children's ward. So basically that is the entrance to the children's ward of Alachor Hospital. For those who have been there, you know how it looks like. Okay, that is another picture of the inside of the children's ward as you know it. This is our duty room, okay? And in the ward we offer both as well as some degree of outpatient care, especially after 5 p.m. when the outpatient is officially closed. And then in the ward, we have general pediatrics. There is a bit of neonatal care. There is management of the malnourished children. And then there is an area for managing oncological patients. And the age groups admitted 0 to 12 years. The exception is usually the oncology patient. For those ones, we can go as high as 18 years of age. Average length of stay for the patient is about 5 days. But the longest staying patients are usually the oncology patients and a few of those with malnutrition. The leading reasons for admission, the admission varies really between 600 and 10,000 per year. But most times it's averaging at about 800. Complication, the leading reason for admission, and this is the same for the outpatient visits as well. Then this is followed closely by neonatal conditions. So you have asphyxia, prematurity, sepsis, and the others, and then anemia. Now, the anemia in this case, we are talking about conditions like sickle cell disease, but sometimes these are complications of malaria as well. The staffing composition, 10 doctors, 2 pediatricians. There are 4 medical officers. These are the general doctors. There are 4 medical intern doctors. There is a bracket there. So out of the 4 medical officers that we currently have, 2 of them are about to leave for school. So by the time I go back, probably I'll find only 2 left. Yes. And then the nurses, there are 21 qualified nurses, and then there are 10 support staff, and this includes the nursing aides, the cleaners, and then there is 1 health educator. How does a typical day in the children's ward look like? So the day usually starts at 7 a.m. with the general cleaning. usually done by the nurses and the nursing aides. And then at 8:30 a.m. every day, with the exception of weekends and Saturdays, we have a meeting. And there are two special days, that's Tuesdays and Fridays. On Tuesdays, we have continuous medical education, where presentations are made and we discuss some of the cases in the ward and anything else that matters for that case. And then on Fridays, we have a general meeting. So on Fridays, we invite even the team from the outpatient, the pediatrics outpatient or the young child clinic to come in for a meeting. And then after the meeting, we have the ward round beginning. And then treatment administration, usually there are designated times, that is at 6 a.m., midday, 6 p.m., midnight. The exception is malaria in this case, because there is a certain way the dosing of malaria treatment is structured. So it's always individualized, unlike the other treatments, which somehow they find ways of harmonizing the times. And then night duties for doctors start at 5 p.m., so 5 p.m. to 8:30. That is when the on-call doctors are on duty. But unlike the nurses, the doctors in Lacho do not do shifts, okay? So we work like, all through, literally. Yes. So briefly, that's the background of the children's ward or the pediatrics department. Now, the RBF, as mentioned by the previous presenters, introduced in 2018, and those were the objectives. But how we understood it, we are looking at it as a system put in place to enable us, like, all the systems to work beyond the infrastructure and the equipment that we already had in place. It was also to help us consolidate knowledge and skills, and then to change mindset, attitudes, and behaviors of the team who are taking care of these children. So in terms of the impacts, looking at those basic areas that, the project really tried to, track, we have the basic infrastructures and environmental safety. So things like doors, windows, and beds and other facilities are now being checked regularly. That means you don't wait for someone to discover that they are broken during the verification. So every team member knows that when there is a problem, you have to sound an alarm, and then we have this fixed as soon as possible, which was not the case previously. Then the environmental safety, the electrical mains are now safe. I think you've seen in the previous pictures. The other thing is a disclaimer, really, that most of the things that I'm going to talk about actually have been highlighted by the previous presenters. Okay, so they have kind of simplified my work greatly already. So we have there is safety storage of drugs, so they are not accessed by children. Remember, we are talking about children, okay, who even when they are sick, sometimes they're able to run around, okay? So you don't want them to, landing onto things that may, endanger their lives. We have fire extinguishers in place, and it's upon the team that they are not expired, so they're in functional state, okay? And then the other thing that is supposed to be a video, it's supposed to be a video. Yes. So that is a video of the training that we had, and then in pictures we had there was a theoretical part as well as a practical part. Yes. And then basic equipment and commodities. So we have the basic equipment that you need in the day-to-day patient care. Pulse oximeters for monitoring, suction machines, infusion pumps, oxygen concentrators, nebulizers, weighing scales, and the rest. Now, we have always had some of these in place, but then there are times, they were there, but, they were not functional. So currently, it's upon everyone to make sure that, we don't just have this equipment, but they're supposed to, help us when we need them, okay? The other one is that we have the right drugs at all times in the ward, okay? And because of RBF, we have a mechanism whereby, ordering is done before the drugs actually run out, okay? The other thing is that for all the drugs and these commodities that you have in the ward, everyone, it's on everyone to make sure that we check for the expiry. Okay, because there are times like, we would have these things, but then when you need, that's when you realize that actually, they are beyond. Okay. And then over time, we have also had improved support from laboratory and radiology. This is not yet at a level where we want. And there are so many reasons for that. But at least we are somewhere. And of late, we have had representation from those two departments attending some of our meetings, especially when there are issues. So it has improved that communication between us and them, because we cannot work without them. Hygienic conditions, the cleanliness, this has been improved. Yes, when I showed the slide on the staffing composition, there were cleaners, okay? So there are already people who are doing some of these things, okay? But because of RBF, it's become like, something that, everyone like, feels happy to, perform such duties, which I think is a very good thing. And then the cleaning products are always available. And there is a proper stock management for these cleaning agents. And then the beds have, impermeable plastics for coverage. So the mattresses are not prone to like, getting like, spoiled by, bodily fluids and the rest. We have hand washing facilities. There are, alcohol sanitizers for the healthcare workers, but there are also hand washing facilities for the patients. And it's one of the things that, we talk to them about every time, like, they come in, okay? Those are some of the things that I've been talking about. So you have hand washing facilities there. This bucket here is for, putting items that have been used. So oxygen tubes, ambu bags, and the rest, the suction, the suckers, once they have been used on the patient, they are soaked in there until, the cleaning time. And the other thing about it is that previously, when these preparations were made, the time and the dates were not indicated, okay? So they could be there for, days or probably even a week. But currently, there is a clear date and time when it's prepared and when it expires, which means the very next day, it's supposed to be replaced, okay? And then this is really waste segregation, okay, for the different kinds of the medical waste. Now, the other thing about waste segregation is that we also have bins for the domestic waste, and this is mainly to target the patients. Now, previously, we did not have that, okay? So they could just dump things like, anywhere. But currently, we have this in place, and every time they are receiving this health education, those are some of the things that, we talk to them about. So this is one of the, one of the ways the RBF project has impacted on the department. The clinical and nursing procedures, now, this has been quite challenging. And a part of it is because of the constant turnover of the staff, okay? So you have a team today, the very next day you have different groups of people, so you have to keep going back to some of those things. But over time, we have seen improvements. For example, we have every time a patient is admitted, there's clear and continuous patient identification on the charts, as well as the treatment forms, okay, which is a good thing. And then there is consent, which is administered. It's no longer an option. In the past, some people would do it, others would not. But for every patient who is admitted, at that point, they have to consent before you proceed with everything. And I think that is a very good thing for us. And then the issues of diagnosis and the rest, this was talked about as well. We have tried to emphasize on good clinical history and some of the key things that currently we try to make sure we ask for all the patients. Immunization history, history of allergies, and the rest. Now, in the past, some people would do this, others would not. So when a patient probably has a history of allergies, no one would know, okay? And then examination, we encourage that this is supposed to be guided by the history, and then investigation should be informed by the history and the examination. So that traditional way of the patient clerkship is what we are emphasizing, okay? We live in a malaria endemic setting, And for any child who comes in with fever, it's supposed to naturally come to you that, malaria could be what? The problem. So we expect that, for every child who comes with fever, we exclude malaria. And then we have also observed increased use of protocols and guidelines. This helps in the diagnosis, but as the overall patient management as well. Now, we have always had, protocols and guidelines. Biggest challenge has been the utilization. And these are some of the things that, RBF has helped us to, preach. Every time, we have these morning meetings, every time, we sit, to discuss patient cases, we try to, see if, things were done according to, the different guidelines that we have in place. Treatment, this starts from the prescription, and we think our prescription should really follow the diagnosis. And then there are the protocols or the guidelines that I've already talked about. But the other issue about treatment is the administration, okay? Because for the different medications, especially the IV medications, there are certain rates at which they are supposed to be given. Now, in the past, they were just giving everything the same. Just push and then move on to the next, push and move on to the next. But because of the project, our eyes have been open, and we know that, different medications are supposed to be given at different rates. And we should try as much as possible to follow this, because we're trying to standardize the way we give care to the patient. Yes. And then the issues of death reviews, this was highlighted earlier. So every death that occurs in the department, we try to review them as, as early as possible. And then quarterly we do mortality audits. And so we audit all these files that we have reviewed over time. Now, there are certain deaths, for example, the perinatal deaths, where the rigor with which you're supposed to do these notifications and then the reviews, demand that, you have to do them, okay? Because there are consequences that are attached to that. And because we have been doing some of these things, and we believe that, the project has really helped us to strengthen this, okay? Because everyone now knows that, when this happens, these are the steps that needs to be followed. Yes. And then the other thing about the reviews and the audits is that, these are supposed to be documented. In the past, we would sit and discuss, and then we do not have, every time we try to trace for evidence of these things having happened, it was impossible to get. But because of the project, all these things are minuted, so that in the event that you want to follow back and see what has been going on, you have, the evidence, which is a good thing for us. The protocols and guidelines. And then every time, there are a list of emergency drugs that are supposed to be in these boxes, they are always supposed to be there, and we have to check for the expiration as well. Protocols are available, like I mentioned earlier. So we have the WHO guidelines, Uganda clinical guidelines. There are also guidelines that have been developed by Lacho Hospital, okay, in place. And then we have also had some training on some of the protocols, things like, resuscitation of the, the unconscious or the very sick child, the newborns, and the rest, okay? And then the other important thing is that because of the project, we also have improvement in the handover patients, especially the critically ill ones, okay? So at least we try to make sure that if we have very critically ill patients in the ward, everyone in the department is aware of these patients and where they're the part in the department where they are located. Trainings, whenever available, the students have been encouraged to come up with clear written objectives to be in the ward. They are around. Okay. Those are some of the nursing students, and then objectives again. And then there are other observations in terms of the impacts. Now we have duty rosters for all the different categories of doctors in place. In the past, we would only have for the interns and maybe the medical officers, but currently, even though we're only 2 pediatricians, we have a duty roster with the contacts and everything. So every time someone needs help, they know who to call. And we think this is a good thing. Evidence of routine meetings and consultations is now present. And then for every patient who is admitted, the time of admission is always indicated, which was not the case previously. And there's been some improvement in the communication. how we communicate to these patients and all that, and we think this is really an outcome of this project. Then we have the views from the other team members who work in the department, okay? So some of them observed that this project has provided a platform for actual problem identification on the ward with key areas for improvement. So the members are more aware of their surroundings and what they're supposed to do. The other one is that the project has increased transparency in communication between staff and the mid-level managers and subsequently the top management, which is a very good thing. There is better consultation and discussion of cases. It has improved the interdisciplinary management of patients because of better follow-up, for example, with the radiology and the laboratory departments. This is a huge plus. It has improved cooperation between the nurses and clinicians in patient care. So the nurses are now more aware of their great contribution in patient care. And this has promoted better teamwork. I think it was highlighted by the previous presenters as well. And then the nurses are more visible in terms of attendance and participation in departmental activities like continuous medical education, meetings, and audits. When some of this verification just started, it was one of the biggest challenges, getting the nurses to attend some of these meetings and also not only attend but participate. But there has steadily been, an improvement in that area. So there's better documentation, record keeping. There has been encouraged utilization of the available guidelines and protocols. But also there is better utilization of investigation results because we require that these investigations are quoted in the patient's medical forms. Yes. And then the other one is, I don't know where I can put this. I feel the project demands a lot, which is good, but for an understaffed department, it needed to advocate for more staff to better execute most of the quality standards. RBF often masks certain bad habits like poor waste segregation, maintenance of equipment, as well as emergency preparedness. This was often manifested by inconsistencies. So these are some of the things that were observed in the beginning. But the team appreciate that, there have been changes, okay, in some of those, okay? So there were some of the weaknesses which were observed in the beginning, but over time, they appreciate that, there have been steps in trying to make sure they are mitigated. There's always some level of anxiety among a section of the staff whenever they receive news of impending verification. Okay? So I'll tell you that before this project, there were certain verifications that would take place over time. But it looks like the approach of the team that would carry out this was not very friendly. Okay? So it always created a lot of anxiety. And this was the case with this one as well. So people were expecting that same, hostile environment. But surprisingly, the verifiers have been very interactive, very friendly, and it's a good thing that has changed. And then the other one is that most staff had poor attitude towards the project and struggled to make it a part of their routine. They also seemed to do certain things just to impress the verification team. So those are some of the things that the team appreciates that, it has changed over time because of the project. So some of our key learning points from the RBF project is that it's always good to start with what you have in place, okay, and try to make it better. Help will always find you on the way. So you're not going to wait until it is there, then you start. You can always start with what you have. And then the other one is that having what to work with can be one of the best motivators for healthcare workers, okay? So you don't have to wait until you have all this fancy equipment in place. You can always make do with what you have, okay? And then if the system enables you to have the basic things that you need to work with, that kind of drives you to continue, okay? And then lastly, most of the incentives, as you have heard, have been monetary in the form of improved infrastructure and all that. But probably it's time we also think about, capacity building and, things like training, further training for some of the staff as a way of incentivizing them. Yes. All right, that's the end. Thank you.
Thank you, Dr. Venice. Now the next speaker is Dr. Maurice Ocao. Next is the future pediatrician of Kalonga Hospital. I'm very happy and grateful he is here with us. He has to cope with some challenges because he's ending his master in Makerere University. So thank you to be here.
Good afternoon, everybody. I hope you are still fresh. The challenge with having sessions in the afternoon is that most people usually are sleepy after lunch, but I hope we are still fresh. So I'll quickly talk about the impact of the RBF project in Children's Ward of Kalonga Hospital. And what I must say that for Kalonga Hospital, the RBF project has really had a tremendous effort and a lot of dedication and commitment so that we achieve our goals. So quickly, that is the outline of my presentation. We shall have a quick background of the facility, and then we shall see how did we implement the RBF project in the hospital, what were the outcomes, what were the challenges, the way forward, and we shall have acknowledgements. So is the rock. If you manage to see the rock, then you're in Kalongo. And something else about Kalongo Hospital is to be able to provide the best quality of service to the very needy person who is not able to get that kind of service from somewhere who is in another region of the country. So that is something that is very unique about Kalongo. So quickly again, we can look at Kalonga Hospital has 271 beds, and it has different wards from the surgical ward, medical, pediatrics, obstetrics and gynecology, private wards, laboratory and radiology. But we also need to take into account that the other general healthcare services that are still provided by the facility include curative, promotive, preventive, rehabilitative services, and Kalonga Hospital is also a site for specialist medical camps. We've seen so many camps that have been organized in Kalongo to try and provide some of the specialist services that the people of Kalongo may not be able to get. So still attached to the hospital, there is a health training wing that is a midwifery training school. And currently it's offering both the certificate and diploma courses. However, the long-term strategic vision of the institution is that there is a plan to upgrade the school to be in position to offer a degree. So how did we implement the RPF project? I think it is very important that we understand this cycle, because before the process of RBF, when we had a meeting with Luigi Greco, this is how we started. We started having a meeting with him, and then a standard for assessment was set. But you must take note that when the standard of assessment was set, there are certain parameters that could be assessed in Kalongo and may not be, could be assessed in Lacho and could not be assessed in Kalongo. So it was a little bit adjusted, and I think that was really very practical for us. And then after having an assessment, then we went ahead to have a series of meetings that were held between the administration and the ward staff. This is really very important, especially when it comes to the issues of having the results. When the results come back, so it's the administration to move down and have a discussion with the meeting and the staff, so that we can have a collaborative effort, so that the staff feel involved in the whole process of ensuring that we provide the best services within the facility. And then from the series of meetings after having the series of meetings, then resolutions are made to have an action plan with very specific timelines and responsible persons. So this is an initiative that is usually supervised by the Quality Improvement Committee. And from there, then there is a monitoring progress. Still, after this has been done, we try to check and assess. We have made this kind of plan and progress. By how far, by how much have we achieved what we are supposed to do? And then eventually we come to an evaluation of the progress, and then we had a final assessment. So for every time there is an assessment, this cycle is repeated, and that is something that has brought about the change within Kalongo Hospital. And I must say this was an initiative within the ward staff themselves, and it made really a very big difference. For me particularly about this whole process, it's something that is continuous, because we try to put it in, we try to put the information within the staff that, you know, ultimately at the end of the day, your performance is attributed to a monetary term. Yes, but I think the perception that the ward staff really have, it's beyond the monetary term. And when I reach to discuss the challenges, I think we shall be able to understand better exactly what is happening. So quickly, you can see the number of patients that were attended to during the assessment period. So you could see, so each bar represents each quarter. So this is in the year 2018-2019, from March 2018 to again February 2019. So for the 3 years during the project, so you can see. Initially, we had a very low number, and then subsequently in the following year, we had a very high number. And I must say Kalongo is very unique when it comes to such kind of numbers of patients. During this time, we had a very huge outbreak of malaria, and I must say this was disastrous. And then the question will be, what was happening here in 2020, 2021? Now, if you can remember, this is March 2020 and 2021, and that is the time we are having the coronavirus pandemic, and it had a very big impact on the number of the patients that were really going to the facility. How corona has affected the number of patients that go to the facility, that one is another discussion that probably we shall have later on, and we shall understand better exactly what transpired. So still, this is what I can say. This is the total scores over the assessment period. We could see the initial assessment was about 64%, but I must say that subsequently, as you can see over the 3-period timeline, there's been a tremendous improvement. So we can see in the last year, all the scores were at least above 85%, which is something that is good from 66. It may not have reached 100%, but I think from the perspective of the hospital and from the perspective of the staff, given the challenges that are there, I think there's a lot of work that was done. So when we talk about the outcomes, the benefits, stroke the improvements within the facility, so we need to understand that the outcomes are looked at different levels, from the perspective of the hospital, then the ward, then the personnel, then what is the direct impact on the patient care. And I think that is something that is worth exploring, other than just looking at RBF in general. But I think it's better for us to try and understand at each specific level what exactly is going on. So from the hospital perspective, this is very paramount. There's an increase in revenue from the bonuses received. That one is obvious from what the definition is. And then leadership roles and responsibilities with accountability. Now, this is very key, because when you talk about the leadership roles and responsibilities, there is an issue of delegation of work here, direct from the administration, going down to the ward management, which is headed by a medical doctor, who in turn acts with the nurse in charge to ensure that what is necessary to be done on the ward is done. So there is a sense of responsibility. You don't need to wait for the administration or somebody from the CEO, Dr. Smart, to come and tell somebody on the ward to do something. Also, I must say that we are also working with a team of motivated staff, really. You can look at it in 2 ways. The staff of Children's Ward are very motivated in trying to achieve a specific target. It is inherent and by human nature. If there's a target that is set for you and there's some motivation that is put, you'll definitely be motivated to achieve that target. And once you achieve that target, it is definitely that there's some unique feel of joy that you get. So I think this is very applicable to us, and this really improves on the outcomes of the staff within the facility. So this improved quality of hospital data, I must say, with the RBF coming in, Kalongo Hospital initially, when you look at our patient files before the RBF came in, there's so many things that we had to do to modify our patient files. For example, introducing the face sheet, the consent form. These were really something that needed to be done, and also capture a lot of the patient biodata. And this improved the quality of data that we are getting. And this is something that is subject to discussion, but the most important thing is about better student performance from improved student supervision. So with the RBF, we saw the nurses and the doctors getting more involved with the students, and this has a direct impact. Since Kalongo Hospital acts as a training, hospital acts as a training unit for the school, so this has a direct impact. So we have seen that from the RBF project. So quickly we go to outcomes of the RBF on the ward. So this picture that you see, this is Dr. Smart giving feedback to the staff, and I think that is something that is very important, to engage the staff in what they have participated in and what the results have come and what does it mean to them and what is it that they can do. Usually the solutions are generated from the staff, and I think that is very important. So the first and foremost thing is about the improved infrastructure to meet the requirements of the RBF. As you will see in the subsequent pictures, the structure of children's ward has really changed so much. And there is also improved availability of drugs and supplies. This was a challenge. And through RBF, this has really gone so up. And I must say, it directly translates to better quality of care, with improved usage of guidelines. A lot of guidelines were put up on the wall, so people who are managing the patients are able to follow the guidelines to manage the patient and follow appropriately what needs to be done. Improved documentation and record keeping. Still, this goes back to the information that we had ideally, modification of the patient charts, to help us capture data, and this is what I just mentioned earlier on. And there is this issue of reduction in hospital-acquired infections. So just quickly to understand how this came into play, you must realize the children's ward of Kalongo is a 66-bed capacity, but with a surge of the malaria cases, you can have about 120 patients for a 66-bed capacity. So that means that most likely for each bed you're going to have 2 children per bed, which I think over time that the RBF has come in, there's been modification in infrastructure and the bed capacity is going to increase, and that is how directly this comes into reduction in into the infections that will occur within the hospital. Because if you have 2 children sharing a bed, you don't know the infection one child has and could easily transmit it to the other child. And so this becomes a very important point for us. So this is still the development of initiatives to achieve the targets. So this is a tool that was designed by the quality improvement team, which is also still part of the children. And this is the biggest thing that has been the driver for the change. As you can see here is the comment, and then here is the action plan, and here is the responsible person who is supposed to do that. And this is a time frame that is given. So periodically this is re-evaluated. So beyond that, there's also team building, and I think generally we have been discussing about team building, and then there's also a sense of ownership. People feel they're involved and they feel that this is their own effort and strength to ensure that they achieve the targets of the facility and RBF in general. So you will see that this is a renovated building, and you can see there's much bigger space and a better duty room as compared to originally, which you had a small room which was, even during daytime, it looked like it was evening. So I think there's been a big difference. The duty room was really very squeezed. So there's been a very big change in the infrastructure, and this is really one of the things that has come as a result of the RBF. And also within the personnel, some of the things, better leadership and mentorship, as we can see. there is involvement as the doctor is doing the ward round. There is a discussion that sometimes goes on, and if there is a particular case of interest, everybody is involved, and everybody is asked the question, what is your role in ensuring that this child receives the best quality of care? How do we ensure that this child recovers from the illness that he's having? Then there is improved clinical skills and nursing care. Given the fact that we don't have, within the 3-year period, we didn't have a pediatrician who was constantly available. We had an expatriate who was coming in, and still during the occasional visits by the expatriate, the pediatrician, you'd have improved the clinical skills and nursing care, and this was really something that was very beneficial. And then there's also still from this, then you'll eventually end up with continuous professional development. And this is the most important, increased accountability. If you're given a role, if you're given something to do, then you understand that really I'm the one who is supposed to be able to make a change, so you are accountable for it. We ask you questions, why isn't this happening? And then also definitely value and think upon it. So we had a number of patients giving feedback to the staff, and what they noticed that had changed over time, there's timely service. And how does the timely service really affect the quality of care? Before the RBF, you had staff who are coming in who are going to attend to maybe sick children, and you're not certain about exactly what to do, probably because there's no pediatrician, there's nobody you can consult, so there's a delay as you try to figure out what to do. But with the RBF, there's increased supervision and professional development, so the staff are much more aware about what to do. They follow the protocols and the guidelines which are on the wall. So there's timely service, there's a reduction in the patient time. So that eventually results to a health worker who is very confident. Once you have a lot of information, you're very confident. If you don't have information, your level of confidence is reduced. So still, sometimes it was a challenge. The patients would go on the ward sometimes in the night, and this was a problem. You would find the drugs and the sundries are not available. But through the RBF, I think this has been much more available, and this is really a big change. Patient satisfaction, yes, this is very subjective. As I can tell you that different patients have different expectations. So this is another subject for debate. And so when we are talking about patient satisfaction, we need to be very careful. But it is worth mentioning that for a particular set of patients, they really feel satisfied, and we cannot dispute somebody's opinion. It also needs to be considered highly. And then there's something called attendant fatigue and stress. Or in other terms, you'd say the caretaker fatigue and stress. So this is directly related to the amount of time that you spend in hospital, the severity of the illness of the person you're taking care of. So with the confident staff, timely provision of the service and availability of drugs and services, you'll eventually end up with a caretaker who is less stressed and who is less worried. So this is a benefit that comes directly to the patient. For me, the challenges that we see with Kalongo, there is this issue of the limited laboratory menu for diagnostics. Sometimes you have very, very sick children, you are doing everything you can, and really you're still struggling to make a diagnosis. But I think these are some of the challenges. You're not able to do blood cultures, pathologies, and sometimes the issue with the electrolytes. And so, for this, really, this is part of the diagnostics that I think we shall be able to discuss on the way forward and how to be able to tackle it. And then there's the issue of the inconsistent radiology services. And you must realize Kalongo is very far. It's very difficult to have somebody staying there for a very long period of time. You get one radiologist today, will spend 2 months, 3 months, and goes away. So it eventually results into us having very inconsistent radiology services, and yet, when the assessment is being done, they want to make sure that you are constantly in position to provide radiology services, which is still part of quality of care, to be able to make a diagnosis under the diagnostic purposes. So this is something that I really wanted to touch with a lot of caution, staff turnover due to the remoteness of the place. So I'll start from the level of the doctors. So in a period of 3 years, from the time I was there, you've had 5 doctors who have been the in charges of the pediatric ward in a period of 3 years. That is something that should be alarming, okay? So this directly affects how the performance of the ward will be, because every time a new doctor comes in, you have to take the new doctor through the whole process of understanding what exactly is going on. And this is where the catch is, as we have been discussing over about improved skills, professional development. And so for every staff that comes in and we do the mentorship, we train the staff, they get the appropriate skills, they get the knowledge, they become much more confident, and that obviously affect the process of the RBF and still the quality of care. So the issues about behavior, the last issue to discuss here is about the behavior and the attitude of the caretakers. And we need to talk about waste disposal and hand washing. This was really a very big challenge in the beginning. But I think over time, we have, through the health educations that are being conducted every morning, informing the community, the caretakers of the patients what needs to be done. I think there's been a big improvement. It's still a challenge, but I think there's something that can be done about it. And the way forward, I think we need collaborations. Lacho is able to do what we are not able to do, and already we are through the process of having so many collaborations and understanding, and this is really key for us to ensure that what we cannot be able to do to Kalongo, still the patient is able to receive services, so that we can have an interaction with Lacho. For example, blood cultures, it would be possible for us to take off blood samples and send to Lacho, and these tests are done and we get results either through mail or any other way, and still the patient will be able to receive the best quality of service. So staff incentives, other than just giving monetary terms, and this is where the challenge comes in, because money is there, but this may not be the only driver for somebody to stay in a particular place. So we need other things. Career growth opportunity could be something that we could also employ to ensure that the staff really stay on ground. And then there is continuous health education of mothers. And I must say that changing behavior of an individual is something that is very hard. And behavior, attitudes, and perceptions are really something that are not so easy. So it is a continuous process. So I think to some of the problems, I think this is what can be done, and continuous involvement of so many parties and partners in helping us achieve our objectives. And then this is really very important. This is how far we come. We have come. This picture is particularly important for us because this was the very first meeting before the RBF. There's been progress, tremendous progress. We have a larger room, a larger duty room, and this is the neonatal care, improved neonatal care. When you talk about mentorship training, Dr. Tito, the expatriate who is the visiting pediatrician, going usually for 3 months and then takes a break 3 months. And I think it has made a difference, and this is what we are really encouraging. But I think the issue of the pediatrician being absent from Kalong, I think that is something, at least one of the things that is going to be solved with effect from next year. I think that was my last slide, and these are, I want to acknowledge all the parties involved in this process of RBF. And finally, from us in Kalong, we say thank you.
Thank you, Dr. Maurice, for your very useful presentation. So I think we are perfectly on time, and the next intervention should be by remote by Professor Missoni. So we have to connect with him. Professor Eduardo Missoni is from Bocconi University. Is professor at the School of Management of Bocconi University. Is a research fellow at Cergas, the Center for Research on Health and Social Care Management. He's already connected, I don't think. He's coming. Yes, from Mexico.
Here I am, sorry. Sorry.
Professor Missoni, we hear you, we don't see you. Good afternoon.
You should be able to see me too. Sorry, I had a conference before and was late for this.
Okay, we hear you well now.
Good.
Welcome, good afternoon.
Good afternoon to you. I'm just looking to find my presentation so that I will be ready with you for everything. Just give me a second because I had a conference from 3 o'clock to 5 o'clock in the morning. So
now we see you very well.
Okay, I'm just coming. Just looking for my presentations here because I didn't prepare it. Where are we? Very sorry for this. Okay, this is training, and here we are. Okay, perfect. And back to you. Okay, so you tell me we want to start immediately? Hello?
No, non ho sentito, scusa.
I cannot hear
Yes, you. Yes, thank you.
We do start?
Yeah, okay,
so
perfect.
I don't know, I only see one person there. I imagine there is somebody in the room, I suppose. Yes, okay, so sorry to everybody for this being a few minutes late. As anticipated, I am broadcasting from Mexico, and due to the 7 hours difference, the conference I gave this morning was with Basel in Switzerland, and I had to give it at 3 o'clock in the morning. So my I am with a little jet lag today with you. But anyway, I'm very, very happy to be invited by your university and to be able to participate, although at a distance, to this a beautiful event. I must say, I know the beautiful story of the Lacor Hospital, with many friends having worked there. And although I've never been there, it's a known story to me. Having worked, by the way, during 15 years with the Minister of Foreign Affairs in Development Cooperation, also in charge of Sub-Saharan Africa, I obviously have had some connections with beautiful stories from that continent. And today, what I want to discuss with you is, well, you have been discussing on results-based financing, so I will take a different story today, and is related to the training of doctors, especially doctors. It will not be only about doctors. When we speak of training of health professionals, indeed we speak of different categories, but I will focus more on doctors because I think there is a paradigm that needs to be changed. In my title, I included health professionals for sustainable health system. We all speak about sustainability, and possible results-based financing is part of sustainability at the local level. But I will look at sustainability from a wider point of view, from the point of view of a health system. So in my agenda, I will look at, first of all, of what makes a healthcare system sustainable or unsustainable, how we prepare health professionals to work in those health systems, what kind of awareness they have about a system approach, how medical education developed in the context of international cooperation, or if you prefer, development assistance. So the North-South approach, which is the traditional one, a little bit historical, and then understand health in the wider development agenda, and to conclude, to respond at the first question, what is the kind of human resources we need for sustainable health systems? So let's have a look, a very comprehensive look, but very synthetic look at the same time, on how a health system is organized. This is a traditional framework that we know with the main functions or building blocks of a health system. And what I'm pointing out here, there are a number of determinants, factors outside any health system, whether in the north or in the global south, doesn't matter, rich or poor country, doesn't matter. In all of these, in all systems, there are external factors which have an impact on the functioning and, as a consequence, on the sustainability of systems. My thesis is that they make them unsustainable. And therefore, under certain circumstances, especially low resource settings, obviously there are some factors which have a higher impact. For example, countries who have weak economies that have to follow some imposed policies by international financial institutions, or that have followed models, health system models, highly fragmented and privatized, that led them to heavy out-of-pocket payments, impacting on financing. And so on the different functions of the system, we have external impacts. Regarding offer and demand of services, we have, for example, the very enormous importance of environmental determinants, societal and determinants, including marketing and including the behavior of the doctors with excessive prescribing. We have factors which affect health from the agriculture, from the agribusiness, for example. So all these factors modify demand. We have an increasing number, an increasing burden from non-communicable diseases that services have to face, and that need a completely different approach, including in clinical terms. Today we are specifically interested in two factors. One is how education of health professionals may influence positively or negatively the system and the capacity of the system to respond to the needs of the population, and eventually to recruit and maintain the health personnel that systems need. And the second element is how global development assistance through many different actors, bilateral, multilateral, global philanthropy, corporate social initiatives, and so on and so, academy, and so on, may influence the system, bringing each of them different criteria. This is so the picture that we have in this moment with these determinants that I illustrate in the slide as what makes, from my point of view, a system unsustainable. But let's go into the very subject of my presentation, which is education of health professionals. And I focus on medical doctors, first of all, because I have more experience about this, and second, because I think doctors represent a paradigm in training. In 1971, so long time ago, a very well-known Italian public health expert, Giulio Maccacaro, wrote, "There is no graduate course nor specialization course educating a medical doctor who is able to integrate usefully year of the graduate school in medicine and surgery." And there I teach a course which is known as Social Rules of Health. And when I entered the first day in my course, and I have some 100 students in front, an international course, so I have students from China, from Africa, from Latin America, from many countries in Europe, etc. I put them a question. I asked them, why do you want to become a doctor? And normally I have this kind of answers, responding to the needs of suffering people, being useful to community, also some more research-oriented or scientifically oriented approach, which is, I like biology, I'm interested in the function of the human body. And somebody also very honestly says, to gain reputation, a social status, eventually to have a good job. But then I have my second question. And my second question is, what kind of doctor do you want to be? And amazingly, we have, the response is, you have all the possible range of specialists, cardiologists, neurosurgeons, ophthalmologists, endocrinologists. They appear to know all possible specialization of the course. But over my 100 my students, rarely I have somebody who says, I want to be a community doctor, I want to be a general practitioner, I want to be a psychiatrist, or even less, a public health expert, a doctor in public health. Is this surprising? It is not surprising, because students, before becoming students at university, they have gone through adolescence. They have been looking at TV series. They have been influenced by the outer environment. And what is the proposal? What is the image of the doctor? What is the hero doctor in the global imaginary? It is a highly specialized man or woman which works in a very complex situation, facing emergencies, last-minute solutions, and normally solutions which are provided with high and complex technology. The higher the complexity of the technology, the higher your reputation as a doctor. This is the imaginary. And if you look for a hero in a doctor in a community level, in a series, you may only find a series which is known as Dr. Martin, which is a UK series where the doctor is an anti-hero, is a very complex person, a person who has a lot of psychological problems. So the anti-hero is the community doctor. The hero is the specialist. That's why they come in and they already have their idea, because they want to follow Superman, and their Superman are these kind of doctors. What training do they receive then along the course of university? What I call the top-down training. Not only top-down because you have a professor speaking from his or her experience down to the student, but because students are invested of their power of being future medical doctors and look from top down to the patient, to the person, which is not a person, is a horizontal sick patient, lies in bed. We are all trained to work in hospitals. And this has not changed over the last 50 years. And what about the human being? We have no training. I mean, again, this I'm generalizing. There are universities who already are providing some of these inputs. And in Pavia, we tend to give some information about these issues on the first year of graduate school. But nobody normally, I mean, in generalized terms, I can say that the condition in which people are born, grow, work, live, and age, which is the definition of social determinants, is not taken into account. And how can we take care of a person if we don't know anything about her life, the condition in which he or she lives, works, etc. So this is really something that we have to face. So normally health determinants are absent from the curriculum. Community health is not this teaching, less so anthropology, social medicine. And what about soft skills, working in team? Maybe this is in the new teaching, this happens, but intercultural competences are totally forgotten. Interdisciplinary, speaking with engineers, speaking with architects, speaking with environmentalists, this is rarely seen at school. And forget global health. I will come back on this. Emphasis is still on disease, tertiary care, hospital, as we were mentioned. And then medical schools are isolated from the national health systems. The university prepares a doctor, which then has to insert in a medical system that has never had a dialogue with the university. And very often the competencies you have developed had nothing to do with the community. The institutional culture in universities is rewarding more research. What are your publications? Did you publish in a review with a high impact factor? This is what makes your career, including as a professor, instead of saying, How well were you accepted by your students? How much did they learn? How inspiring were you with your students? Nobody put this question. It's not part of your evaluation in the university. And this applies also to other faculties. The focus, even in research, is on marketable research, research which is financed by the multinational, transnational companies, which have obviously different interests of the interest that we as doctors, as health professionals should have in dealing with people, not patients, people. And at the end, also when you come into the hospital, when you come into your community care, the reward, your professional reward, is not linked to the health outcomes. If you spend years in a community, in an isolated community, dedicating yourself 24 hours to the people, always available, this is not, you have a personal reward which is enormous, which is moral, but the system don't consider. You don't have a higher reputation because of your dedication. You have a higher reputation if you are a highly specialized expert. And what happens as a consequence? That you lose contact with the community. Obviously, in some countries, for sure in Africa and in Latin America, a continent that I know much better, there is a failure of secondary education, which prevents students to access university. But nearly half of the countries worldwide have no medical schools or very few ones. Teaching is normally in capital cities, in hospitals, specialized institutions. Students are recruited in which are not representative of the population. They are representative normally of a middle-high class and from people who live already in capital cities, in urban areas. And also the way how we teach, it disconnects from reality. And for example, from issues like traditional medicines or cosmovision of the population with which we want them to take care of. And what is the consequence? The consequence is that our wrong investment is producing export quality doctors. If I asked where do most of the African doctors, let's generalize it, work, the answer will not be Kampala or Cape Town or whatever, maybe Cape Town. It will be Boston, London, will be any town or capital or prestigious place somewhere else in the world. And many of the African doctors have the ambition to go north. This is a problem, is not their problem, is the problem of the system who has invested on that kind of people, because we have privileged competences which are not the competences which are needed in the country where they come from. And obviously then there are also other systemic conditions like low pay, low reward, impossibility to apply all the things that they have learned to work in a hospital. And therefore they leave the community for town, for big cities, and from big cities they leave their countries to the north, where eventually they're not even employed at the level of their competences. And then we come into medical education in international cooperation. We still are linked to institutions in the north. It's less and less. This morning I was giving my conference with TROP-ED, which is a network which includes also institutions in the south. But it's a long-standing tradition that training for working in countries in low-resource settings in the global south, training is given in institutions in the global north, which still keep the focus on tropical medicine. I'm specialized in tropical medicine, and I always tell my students I'm specialized in something which does not exist. Why I say this? Because tropical medicine is a colonial heritage. It has nothing to do with the reality of disease. And there is no single disease which is defined by latitude, eventually by climate. Now look at the picture I propose you. That's not an African picture, it's a Latin American picture. This is the city of Potosí in Bolivia, and miners at work at 5,000 meters over sea level. Do you think you can find one case of traditionally considered tropical diseases? No. You find all the possible diseases of poverty. And this is the issue. You find diseases which are, or health conditions which are related to the work you do, to the social environment. And then we find, I looked for the definition, for example, in the UK National Health System of what a tropical medicine should be. And they say people, doctors who treat a wide range of tropical infection like hepatitis. Hepatitis has nothing to do with tropics. And so really we have to leave behind. We shouldn't speak of tropical medicine, not even the World Health Organization who speaks of neglected tropical diseases. And they do this only for their own bureaucratic organizational reasons. I cannot go more in depth here about how the WHO is organized. There has been a cosmetic change. Tropical medicine, a colonial heritage, has been transformed into international health, and many institutions that now call themselves global health institutions. And they speak of global health experience that they provide to their students. Now, especially in North America, and especially in the US, I must say. In Europe, we have a slightly different approach. But when we propose a global health experience, is any medicine practiced in poor countries in the global south? That's not global health. And that's not even tropical medicine. That is medicine somewhere else. Medicine in a low resource setting where you go and make some experience, sometimes on the disadvantage of people there. This is a typical North-South approach, sometimes including partnering. I don't know the partners of the Lackford Hospital, but it's very common that the institution in the North partner with medical schools in the South, and there this partnering is at the full advantage in terms of research, in terms of training opportunities to the northern schools. And even more in development assistance, too often, I have seen this all my life, that you have professionals from the North go to global South, I use this term because it's comprehensive, and then train locally staff according to Northern standard. What do they know about the reality in African countries? They learn there. We have learned. I started my profession in Central America, and I learned there. I didn't teach, although people would imagine I would teach. We bring with us Northern standards, Northern culture. We are still colonizing what is called global health. And global health, now it's more and more literature, needs to be decolonized. Now, coming to the other argument of my presentation is how this fits in the wider global development context. What is a global health approach? Now, I've been working quite a lot on the definition, and actually we have been introducing the definition, unless we have misinterpreted global health. If we have only called global health a cosmetic change of tropical medicine, then of course we need many other aspects to be explored. But if we understand global health as the relation between globalization and health, and how the health of the globe must be faced, then we are in the right direction. It's interdisciplinary, it's intersectoral, it's intercultural, and we need to introduce these competences in the global health expert. It is a moral commitment for health for all and equity. We stand on one side, those who work in global health. We take this decision. We have an approach which is a One Health approach. We consider the connection between the rest of the planet and humanity. If you want, today with the pandemic, we are facing a zoonosis. We cannot forget the health of the animals or health of the plants and the environmental issues if we don't, in order to face human health. We need this systemic approach, which is a whole of society approach. We cannot leave aside those transnational determinants that I proposed you at the beginning as factors of unsustainability of the health system. So we really need this integrated approach. And let me highlight this. It's an ethical commitment. It's an intergenerational commitment too, because we have a responsibility to our future generations. Ethical means looking for the common good, having no conflict of interests when we work in medicine, when we work for health, because our interest is the people, and we cannot have any interest which goes against the people. Our profit would be a conflict of interest unless it is ethically determined. You see, I have nothing against a salary, obviously, but it's really how we pose ourselves in front of the community that we are there to serve. The integrated approach is part of the global agenda. You all have heard of the Agenda 2030 with its Sustainable Development Goals, 17 indivisible and universal goals, means really relates to the whole of humanity. Really every single goes as sustainable, sustained growth. We cannot grow indefinitely. Growth, economic growth means consumption. I know there are economists there. So it means production, consumption, economy which wants us as consumers, not as global citizens. And this is not sustainable. This is exactly the system we have to change. In a few days, there will be discussion of the leaders of the world about climatic change and COP26. They will discuss of the climatic change, forgetting that everything starts in our daily consumption. It's not an issue of modifying technologically how we produce energy. It's about what we consume at the end of the chain. If we have business who will still push us to consume more and more anything without any environmental sensitivity, then we will build an unsustainable world, and we are going in that direction. But if we want to work in global health, we need also to understand the governance. We need to see how the forces, the power and forces move in this environment. In this slide that I modified by Dodson and other authors in 2002, the most relevant one, and then we have the G8 with their policies, their proposals, new global public-private partnerships, especially the Gavi, the Global Fund, and many others which are really crowding there, the Bill and Melinda Gates Foundation, which is practically the single individual, actually the family, which determines the policies in the world today. It's financing 15% of WHO total budget. I imagine that my co-author and good friends Nicoletta Dentico this morning has spoken about the influence of these global philanthropies and of this multi-stakeholder approach that we are experiencing at the global level. So the world is changing, and even if you work at Lacor Hospital, even if you work in a small community, you are influenced by these decisions taken at the global level, so you need to be aware of those powers, those forces who modify your daily life. Fragmentation is another enormous issue, and that is against any principle of aid effectiveness that have been defined in Paris in 2005. Ownership, alignment, harmonization, all is forgotten. It's all in the discourse, but not in practice. In practice, the burden that in terms of, in legal, administrative term, organizational terms, this institution posed on the local officer, on the local staff is enormous. They have to deal with all of this. I've been part of that story, so I know exactly what the burden that a consultant coming from Europe poses on the local officers, who obviously wants to receive properly, wants to offer a lunch, spending some time with that consultant, and then he or she has to repeat this operation with all the consultants which come from around the world, from all these institutions. So we have to create awareness in the northern DNA in order to be able to go forward. And there is a big decision we have to do. Are we interested in health? Do we want human resources for health? Do we want more Asclepion, means medicine, biomedical approach, or do we want more Hygeia, in the Greek tradition, the goddess of health rather than medicine? And if we want to produce health as a comprehensive state of physical, mental, and social well-being in the definition of WHO, and not merely the absence of disease, we have to make this choice, or at least combine very well the two aspects. So what do we want? How do we form now? How do we train our health professionals? Focus on health rather than diseases. Focus on their determinants, understanding the context, social, economic, environmental, cultural, political, governance. We have to favor the recruitment of students from the community to be served. We have to facilitate basic and high education to ensure that when they come to the universities, really those people who have been suffering in the community know what suffering means and are able to become those doctors, those health professionals that we need. A health worker is a community project, it's not an individual project. We have to provide experience and training in the community. And even when we work with expatriates, let them call like this, I mean students from Europe or North America, which travel and have these global health experiences that is being called, it is very important that this community is not only in the hospital, it's not only just reproducing with low resources what they learned in the university. It is a really groundbreaking experience in understanding the community, knowing what it means washing yourself in the river, or even not being able to wash yourself because there is no water. Understand what it means to eat 3 times a day or just 1 time a day, always the same food. I mean, you need at least, let's say, 1 month of experience in that sense. But even 1 week would be enough if this experience is really groundbreaking, it's paradigm shifting, it's changing your vision of what it means being with suffering people. You need to be able to understand the local culture, the local professionals, in different professionals, the engineer and the teacher, the priest and the worker. You must be able to have this capacity. As a doctor, you are there to serve. That's why, once again, ethics is an integral part of being that global health professional that we need. And therefore, if we want to train for health profession, not health profession, but for health, those who produce health, we need also to extend beyond medicine. We need to involve in these aspects economists, sociologists, people from political sciences and law and so on and so forth, because we need to create awareness. Diplomats and people from political sciences, more than doctors, define health in the global south. They are those who sit in the assembly at WHO or in the World Bank or in some other institution which decides from the global north the destiny of the global south. So we need to create the importance, the priority of health in those students, in those professionals, and allow them to work with the medical doctors, with the health professionals in order to create that environment that we need. A vision for social justice is fundamental. In our profession, there is no neutral role. We have to take side, and our side is very clear. We are with the suffering people. That is the choice. You see, when I ask this question to my students, why do you want to be a doctor? I want to help suffering people. That is exactly the mission that we have. But to be prepared for that mission, we need to bring in all these additional competences. We need to have a system-wide analysis. We need to learn, including if you work in the most isolated community center, health center, you need to have some managerial skills and to be able to have a dialogue with the local people, to understand what it means really to be a leader in a community, a servant leader. And as I said, the experience of the real world. So at the end, to have a sustainable health system, we have to correct all those sectors. We have to create in the governance on the left of your screen, the governance for health and all issues which are related to the increasing demand on the health system. We have to create there the environment for health policies, making health a priority, not below economic priority. No. First is health, and then we have to create the economy which serves good health. We need to have education. We need economy which serves good education. Economy is a mean, cannot be the fundamental goal. if we don't understand this, that priorities for the people in the street, let's call it that way, health is number one. It's number one. We can discuss with anybody, it's number one. So we have to make it number one for the system altogether. And therefore, there is where we need a paradigm shift. I'm sure you can see it. And I put in red, I marked the box in red because these are the issues that we are discussing here in this presentation. So we have really to reformulate the curriculum one side and understand that development assistants need to change their view. They have to sit around if they want to really assist, if they really want to make, to be a game changer for what is called development, and then they need to be really sitting around the same desk and saying how we do this all together, bringing together our knowledge, respecting the local context and learning from the local context. That's what I propose at the end is a needed utopia. We are living in the world through a deep crisis where we are seeing now geopolitics dominating the decision about how to manage this crisis. A real crisis, but very badly managed, where we have been creating, and I say we because we are all responsible of this, hate among people, those who can and those who cannot, the vaccinated and the unvaccinated, whereby we have a whole continent which is not be able to, cannot vaccinate more than 3% of their people. And even I wonder even if it's really needed, but this is another story. We want a society which is inclusive, where we can have a dialogue, where we can speak to each other, where we work together in a cooperative way, where we think that equity is a fundamental value, where we respect the planet, where we are ethical. We really work for the common good, and we do it together, understanding our differences without discrimination. That is fundamental. It's a fundamental issue for being a health professional, a professional for health. It's the only way we can build sustainable health systems and go toward that sustainable development goal, which sounds health for all at all ages, and where I would add today and tomorrow. Thank you very much. I leave you with some bibliography that you can go more in depth on things that I have been working on. Thank you.
Thank you very much, Professor Missoni, for this very interesting presentation. It forces us to think on this on these major issues. Thank you.
Thank you very much.
So, if there is anybody who has some question to make,
Okay, sorry. There are also some questions in the Zoom chat, so maybe now we start with the people here, and then we read the questions in the chat.
okay, you will read the question, because I don't have it.
Thomas, I think he's asking.
Thank you very much, Professor, for an extremely interesting presentation. One of your key points in the presentation I've seen in the diagram is free health and universal system. Now my point is, what about those areas in which the tax base is simply not there? How can you have free services when the local economy does not sustain, with $200 on average per person, when in the West the healthcare costs $3,000 US dollar a year. Now let's say that of these 3,000, a lot might be reduced, may be unnecessary, but it is still a disproportionate amount that healthcare costs to be provided, and it's not there. So how can the South not be dependent on the North? Thank you.
Yes, well, my answer is, first of all, we can reduce very much that average cost of health in the north and in the south if we have in place policies which control health determinants. I mean, chronic diseases especially are increasing notably our costs, and they are all dependent on social determinants that can be controlled. This is a long-term policy, but we have to start somewhere. So this is one aspect. Healthcare should not cost as much as it costs. There is much more that can be done at home level, and very early intervention. We know it, including from the last pandemic, how much can be done at home before using structures in hospitals and possibly avoiding them. So this is increasing our primary health care approach, and working on health determinants is #1 priority if we want to have sustainable systems. Then I agree totally with you. One of the weaknesses of health systems or social systems in poor countries is the fiscal system, the tax system. There, obviously, there are policies who have to work on that aspect. And there is where we have to take into consideration that we are a global community. There is where we have to consider that cooperation. I mean, I'm a strong believer in, I don't want to have given the wrong impression. I strongly believe in international and transnational cooperation. But that needs to be oriented according to local needs, not to Western standards, but to local standards. It needs to really, again, put enormous input in primary health care rather than on hospitals, ensuring that we have the right training, the right people. This will change the way we manage health, and we possibly reduce the costs on the one side. And then the other, we need to transfer of support, of funds. Unfortunately, this follows inevitably geopolitical interests. That's why we need a political awareness, an economic awareness, in order to be sure that we cooperate and we are not exploiting certain situations. That is fundamental. I mean, the African continent has paid tribute to the North for centuries. So we have to invert this. We have to find a way with fiscal systems in the North that support the global South, and in a way which is cooperative and not only of purely assistance. We know that pure assistance doesn't lead very, very far away. So there is really a paradigm shift that we have to work on in understanding this rare concept of solidarity. But this needs really to be worked together, not based on what we decide in the North, not what is decided in Geneva and Washington, Paris. No, it must be, the start must be a different one. I know it's very idealistic, but if we don't have this needed utopia, I don't think we go nowhere. Well, we will have beautiful experiences. I'm not saying that the local experience of the LAC or of any other, can be beautiful, fantastic, but it's an island. We need systems, not islands. And therefore, there is a long work to do. But I totally agree. I mean, if the society is weak and with it the fiscal system is weak, you don't have the resources. But there are mechanisms that they can work on. Instead of making innovative financial mechanisms to finance a drug or a vaccine, we may need to have financial mechanisms that promote health altogether and, for example, change the way we consume in order to provide resources, better health and resources for health. I know it's complex, but that's why I'm saying we need a paradigm shift.
So, Carolina, I ask you to read the second question.
Okay, can you hear?
Yes, maybe you can remove the mask.
Now? Okay. So I'm just reading here in the chat. Actually, I had seen one, but I think it was deleted. There was one more for Dr. Missoni, but I'm no longer seeing it. So I see two more questions, but about the RBF. Probably you have already replied, and someone was asking the same. There are two questions, let's say for the RBF teams in Lachor and Calongo. I think I read them, and then maybe you decide who can answer. Is it okay? I start with the first one. Many thanks to the Foundation and all donors. My biggest challenge is sustainability. There is need to sensitize the team on quality improvement. My observation is that quality assurance is lacking in some individuals and it contributes to lack of sustainability. Behavioral change is incentive. So the question is, what will happen in the absence of the incentives? Incentive should be directed towards individual performance appraisal in order to sustain quality. High staff turnover also influences sustainability of quality services. So the question basically, what will happen in the absence of the incentives? I don't know if maybe Dr. Emma or someone from the hospitals team want to answer.
Thank you. What happens in the absence of the incentives? You could also ask what happened before the incentives, because at least as a hospital, we decided that the measurements will go on, that the checking of quality, the finding of gaps, coming up with solutions will go on. And we are creating new units, not because there is a donor, but because pediatrics has led the way. We think it is practical in another ward, we'll go ahead. So in a setup like Lachor, it does not depend too much on the bonus or on the incentive. And the incentive is not made to be expected. So there is still a way in which you do evaluation as and when necessary. There's still a way in which occasionally you have a different type of incentive for particular reasons. Of course, the lesson we learned also through COVID, for example, we have had to incentivize some people in the context of COVID, different from others. So I think some thought has been done in our context. And I'm sure that the challenges Kalongo faced by the way in which they incentivize some groups of people, the reactions that they raise, this tend to help us to reflect. But just to say, incentives are not only monetary. And leaders, managers, should always motivate their staff, finding the right mechanisms. Thank you.
Okay, thank you, Dr. Emma. I just read the second question. Again, many thanks and congratulations to all presenters and Lachor and Kalongo staff, both for the great results achieved and for the excellent presentations. I have a question. Is there a complaint response mechanism in place? If so, how is it working? Is it both for personnel and patients? Sorry, I think it's again the hospital's team to answer to this question. Thank you.
Okay, maybe Kalongo will answer for the response to concerns. I think there is patient feedback mechanisms. At least for the context of Lachor, we do client satisfaction surveys. We also now, since 2 years, I think started doing staff satisfaction survey. It cannot be with the same frequency as the client satisfaction, for example. So there are boxes Also, suggestion boxes, there are suggestion books, different departments now with the RBFs, for example, different departments have their own, like in OPD, they write on an open book, so everybody reads another person's comment. In some places, they discuss it in the departmental meeting. In the more centralized suggestion boxes, for example, the administration, so hospital secretary, matron, and the quality nurse, they open this, communication officer as well, and they can respond. The challenge is that it's not very much real time. Usually it's not very much real time, so there is a certain frequency with which they collect this information, and sometimes you may not make very good sense of what happened when time has passed. Thank you. Just also to say, for the case of Lacho, incentives certainly will continue, even when there is no RBF. So whether it is monetary or non-monetary, I clearly see that this is something that the hospital is committed to continuing. Thank you.
Thank you. I don't know if there are any questions. We are close to the round table that we are going to have. So if there is another question, we give short time to answer the last one.
And from Latour, they are saying that they have a question. I don't know if they are writing, so maybe they can write, and if we have some time later after the round table or just before.
Perfect. Maybe we can answer during the round table. We can find answers. So thank you, everybody. Do we have a short coffee break, right, before the round table? Okay, I leave the floor to Professor Greco and to the round table coming in.
Here we are. Buonasera a tutti. Good evening, everybody. So I'm the good copy of the couple. So here we are. So now we do have to conclude this quite intensive day with the round table, whose title is to be respected: Perspective of Results-Based Financial Cooperation. So I ask to come here the members of the round table: Andrea Stoppana, Venice Omono Emanuel, Maurizio Cao, Livia Colvin, Sergio Berardo, Guido D'Urso and Fabiola Didato. I think they sit. Yes, you locate everybody. While everybody is sitting, yes, please. We have 1.5 hours. So we are 9 people. That means that we have to limit our intervention to something like 8 minutes each. And as Americans say, in 8 minutes you can give a lot of information. Also, we would like to expect eventually to further discussion. So we will leave a few minutes for other questions from the net and from the audience. Okay? I want to stress one point. So now, today we have been reported good results from RBF intervention studies. Now, what do we do next? Do we have to apply to perform the same way? Do we have to embark in different strategies? Do we have to foresee other things? Do we have to expand beyond pediatric wards this sort of project in the countries that are presenting today? Okay, so this is the task we have to admit today. So, but for the sake of hospitality, I want to start asking Guido D'Urso to start with this intervention, with this contribution. Is Guido around? Yes. Because Guido is the catalyzer of university cooperation of this House. So we want to hear shortly what he has to propose for the development of more stringent cooperation between the Neapolitan University and Africa. Please, Guido.
Donato, can you hear me? Okay. So I would like in a very short time to give you an idea of what to be the role of university, how university may contribute in addressing the sustainable development goals. We talk about sustainable development goals because this is the framework in which we act, in which we can place in a more general framework the topic which have been discussed today. And in the university we do a number of activities, and all these are related in some way in how we can contribute to development in our partner countries. And we look at Naples, University of Naples, Federico II, has a special role given its position in the Mediterranean, given its position in Europe and links with Italian university and with Europe. And this is what we call the knowledge diplomacy. And we strongly believe in this role because university has four main avenues which we propose to be actors in the role of development, which is education, research, governance, and leadership. University want to be actor in this. Education addresses one SDG, but of course we have seen how, from the experience which has been described today, we can provide students with knowledge, we can mobilize young people, we can provide high quality training. And an example was in the project GuruNap, when I was involved by Luigi as a member of agricultural faculty in exchanging academic staff, or which more recently hosting students within the Partner for Knowledge project financed by AIHS, and again with the Somali National University. So our idea is also supporting research in this country. And this can be done in several ways, and we have been proposing solution, innovation, capacity building, and all these are avenues for development to which our cooperation through university in developing countries can contribute. And it was an example, again, from GuruNap, hosting in Naples PhD students to carry out environmental studies which are relevant in northern Uganda. And again, developing pilot projects for new ideas, for developing researchers, for having a peer-to-peer collaboration with our colleagues. That was the experience we had in Gulu. And governance, we have seen a lot of examples how university relationship can provide a way to improve and support governance in structures in the university. We have been talking about the health sector, but it is very well horizontal to all different activities. And leadership, of course, because university is the place where we facilitate multi-actor debates, where we build partnership, and we can influence the political agenda. So this is, in a few words, what are the perspectives that university are trying to build up together with the actors of the cooperation at all levels, and that it will be the topics of a conference that University of Naples, together with University L'Orientale, will host in Naples about university cooperation for the new challenges for sustainable development. So everybody is invited.
Well, thank you very much. We also, because you underlined the cooperation in a world general concept according to the global health approach. So now, within this task, we have to consider what is coming new evidence for African countries, in which not only anymore communicable disease are the only first large priority everywhere. But there is a rising evidence that non-communicable diseases are becoming as more important. And you understand very well the difference between treating a malaria child or treating an adult diabetes. So I'm glad to Fabio Didato from the Department of Pediatrics, University of Naples, Federico II, to introduce the task for guidelines to approach non-communicable disease. Thank you, Fabio.
Thank you. Thank you. Good evening. And I'm Fabiola Didato, pediatrician and PhD student in University Federico II. And it's a very pleasure for me to present this new project, first-line guidelines for non-communicable disease in children. This book was born from an idea of Professor Luigi Greco, and in particular because of the evidence that non-communicable diseases are increasing in Uganda. So the aim of the book was to help our Ugandan colleagues to manage this disease. In particular, the authors were pediatricians and subspecialists of our department, and they tried to write a simple protocol and easily applicable to in-shore. We have protocols about neonatal care, for example, by Dr. Letizia Capasso, or treatment of seizures of epilepsy, management of children with pneumonia, in particular about oxygen therapy, protocols about kidney disease or prolonged diarrhea, or also management of diabetes and liver disease. This is a first-line guidelines, so the aim is to help our colleagues, and they are not rigid prescriptions, but they have to be used for individualized for the children. We also want to communicate that in the book there are the email addresses of the specialists, so that we are available for online consultations and discussions of single patients to help our colleagues. But also we are open to suggestions and critics for the protocol we produced. This is we hope this is a further steps in the collaboration between Ugandan staff and Italian staff in the context of the GuluNAP project that consented us to spend some months in La Shore. For example, I was in La Shore for 6 months during my training period in pediatrics, and we hope this book can be useful for our colleagues. Thank you.
Well, thanks very much for this instrumental contribute. In fact, to have a guidelines is always something positive. But when we speak about perspective, we need to hear from the first line protagonist of this RB approach. So let me ask both La Shore and the Kalongo Hospital protagonists to express their view on what is going to happen next. So who is going to start? What about Emmanuel? Is here? Yes, Emmanuel? Oh, you want to start? I think you have to come here, yes. Oh, yeah, there is an ice cream? Yes, bravo. Grazie.
Okay, thank you very much, Professor. On behalf of Lacho Hospital, like Dr. Emmanuel mentioned earlier, the end of the RBF project is really not the end of, thriving for quality healthcare for our patients, okay? And as we speak today, the project ended some months ago, but we still had, we executed the same verification that was being used for the RBF project. So we did the same verification just weeks ago. And this, we believe, there are gains that we made from the project, and the only way that we can sustain this is by carrying on, irrespective of whether, fundings are going to come as it was coming because of the things that we are doing. So we are going to carry on with the same quarterly verification, irrespective of whether the project, is extended or not, in order for us to consolidate the gains that we have made. Thank you.
Okay, well, thanks again. What about, yes, we have the, yes, Kalongo Hospital. Where is Kalongo? Yeah. Okay, yeah, you can use that one, yes.
Yes, thank you so much. With the perspective of Kalongo Hospital, I must say Kalongo Hospital has a very unique situation, and already seeing from the tremendous improvement in the so many things we have achieved in a short period of time. I must say the RBF coming to an end doesn't necessarily mean that the quality of service has to stop, but it means that whatever has been started must continue, because the end user also happens to be the patient, must receive the best quality of care at the most affordable rate. And the situation of Kalongo is that it is one of the poorest regions within the country, but the sole goal and the sole purpose and the vision of Kalongo is still to be able to provide services that are of high quality, but again, very affordable. So I think still in conjunction with the foundation, what we are trying to do, we are trying to employ a number of mechanisms. And this is what I've been discussing with a team that is implementing the RBF. I think we need to look beyond the monetary perspective and more of behavior and change. Despite whether the funding is there or it's not there, still what really matters is the behavior, the attitude of the individual to be able to carry on. So this really roots so much down into an individual. I must say individuals are different and everybody has his or her own goal. But as a hospital, we are trying to shape individuals and personalities to be able to understand that giving health to people who are needy is just not to be pushed by money, but to be pushed by the need and the call for being humane. I think that is where we still lie, and I think we are still going to continue with the process of ensuring quality services provided. Thank you.
Yes, but let me practically understand what will happen, say, next Monday. Are you going to keep the same, tracing indicator system, registering information, or even without incentive, making all the sort of inspection and checks that you have done during the RBF sustained program?
Yes, as I speak right now, what has been started is still continuing. There is no stop in what has been implemented. So we have the quality assurance team that has still continuously done the marked improvement in the hospital. We are having continuous reassessment and continuous evaluation and seeing how we are progressing and making an evaluation. Yes. So I think that is still very important for us. We cannot say
are you also trying to propose the extension to other wards or to other units of your hospital? Livia. Devi premere, Livia, rosso devi. Grazie. Verde, vedi un po'? Niente, non ti vuole bene. Prova quell'altro. Dovrebbero funzionare.
Okay, so It was extremely interesting, all the discussions that we've been having today in the Congress and also yesterday in dinner. So first of all, as Maurice said, the foundation, due to the success of the project, the amazing results it has had, the foundation committed to continue the RBF project in the children ward. Now, there is an open discussion, especially after the exchanges that we've had also with the economics team coordinated by Professor Beraldo. And we were thinking of how to address some of the critiques that have also been pointed out by some of the interventions of today. Critiques being, for example, that there could be bias from the person who is carrying out the inspection. Critiques that concern also doubting whether it is only staff who is performing on their best behavior on the day of verification, not continuously. So the proposal was to incorporate in the verification some mechanisms which are not giving only a photograph of what is the situation on the day of the inspection, but they are giving a more in-depth analysis of what is the situation throughout the entire period of 3 months that is object of the verification. So in some way this is already happening because, for example, some of the clinical aspects are being monitored from randomly selected clinical charts from the period. But it could be an idea to focus more on aspects that are not just on the day of the verification, but that are continuously throughout the period object of the verification, to make sure that it is a continuous quality situation and not just on the day of the verification. And secondly, answering your question about the idea of expanding, this is certainly an idea of which both the hospital and the foundation have been converging in thinking that it is definitely a good system, and we are trying to think together about the best way to go forward to expand either in other wards or maybe focusing on some specific aspects of critical management issues that need to be addressed. So this is really an open topic that we have taken a lot of lessons from what has been said today, and we are very interested in hearing what the hospital management and staff think about what the ideas that have been exchanged, and to work together to find a way to expand RBF also on other aspects of care in the hospital. Thank you.
Yes, that means that you're going to apply for another project, for more funds, or you can do without money, with your pocket.
Yes, so we have submitted an application for which we are awaiting feedback. And then we will also discuss first we need to understand, besides the proposal that has already been presented, if there are other ideas that we would like to experiment and implement. And then, yes, we will look for the funds.
Thank you, thank you. Well, then it's time to hear the voice from Rome, from Andrea Stropiano to my shoulder. That, so if... how do you see how the Italian cooperation can see this future of the RB project in those countries?
Okay, can you hear me? Okay, I cannot talk on behalf of Italian cooperation because I'm not working inside Italian cooperation. I'm working in a society accompanying the Agency for Italian Cooperation in dealing with projects. So from the perspective I can see, from my point of view, there is still a large possibility to access funds in future. Funds for cooperation are enlarging, in spite of many people think they are not reducing. There is, let's say, a willingness to continue improving quality. What does it mean, quality? Quality means that all the new intervention must be really based on needs. And when we say based on needs, means based on a deep analysis of the obstacles existing and preventing the change to happen. That means every new proposal must be settled on a deep analysis why the change we want to see is not taking place now. And the evidence must be proved on the obstacles to be overcome. So accordingly to these deep analyses, all proposals must be made evidence-based, and please, when you make proposal, make sure that you are not working alone, because we can never change reality alone. That means the importance of networking with other innovative projects of your area, of your region, of your country, or of the neighborhood countries. Benchmarking means never start inventing the wheel from zero, but start from the best existing, improving it furtherly. Avoid duplications, so make sure that 1 + 1 = 3 and not 2. That means making synergies. That is similar to what I mentioned before. So there are just some of the assets Italian cooperation pay attention to. Nothing new may be, but the attention to those quality aspects is increasing. So working with quality, of course, helps accessing to funds. Nobody will ensure that you will access to funds, but funds exist. And so don't be discouraged to apply.
Thank you very much, Andrea. A few months ago, I live in Rome, differently from my brother Luigi, and I deal with I palazzi. So I heard that, in fact, the cooperation funds are going to be strongly supported by our President Draghi. But unfortunately, Afghanistan crisis came in. And we have already experienced in the past, like a lot of cooperation funds were directed to Iraq, Iran, and other crises around the world. And this was suffering for all the NGOs that were surviving on those sort of funds. So I hope that the engagement in duplicating the entire budget for cooperation, that was one of the Professor Draghi promises, will take soon place, even if we don't see yet numbers in the proposal financial laws that are running in these days. Well, I believe that now we... yes, un momentito, che giro il dito, la prego. E lui è un ansioso, non è colpa sua. Anch'io sono ansioso. Yes, I was just going to Sergio, because in fact Sergio, together with Luigi, has been the soul of this entire adventure in this beautiful room. So, and also you developed a large view on this sort of cooperation for RBF projects. So what do you see the next 3 years? What will happen in the next 3 years in this specific field, Sergio?
Well, thanks very much. It was really interesting for me as an economist to confront with very different views. Actually, you know, academic people have a tendency to look at the world from their own perspective, which is their desk. And maybe some of the things I said might be not totally true. I mean, in the sense that maybe when you leave the particular social context in which the RBF program is implemented, maybe you realize many things that you cannot see when you are in your office at the university. So, and this is a point I want to stress, because listening to the talks of our Ugandan brothers, I would say, I learned lots of things. Maybe we look at things as if they were black or white, but maybe there is gray, and maybe there are different nuances of gray. In general, I think that the RBF approach is a valid approach. The point is a point of reputation, as quite often, happens in human affairs. So, if we manage to implement it in the right way, if results are reliable, if we push behavior in the good direction, looking at needs, well, we acquire a reputation that we can spend in many occasions. If we do not take this chance of acquiring a reputation, then problems arise. So I think that a very good job has been done so far, but there is other job to do. We can design the evaluation in a more reliable way. This does not mean that the previous evaluation was not designed properly, but in doing that, I think that we have learned lots of things. And so, in a sense, we are obliged to take care of the things we have learned. So, and then we can study how, for example, incentive, because there are many dimensions which are really difficult to measure, but are really important, and many of you have highlighted these dimensions. For example, the development of soft skills, the development of the capacity of interacting with the other people at the world. So these are skills which are really, really important, but we do not have any measure to prove that these dimensions have improved. So looking at this dimension is good. Looking at the persistence of incentives, and this is something I discussed with Luigi many times. So after you have provided incentives, what happens? Our behavior changed in a persistent way. So this is very important. So if we manage to, reassess our goals and methodologies, I think that we can improve what we have done so far, and the benefits will go to all the marvelous children that we saw in the screen today.
Oh, grazie Sergio. Well, it's some 30 years that I happen to be periodically in La Shore for a number of projects. During several of these years, I discussed with Thomas Molteni about a system to improve quality and indicators and this sort of thing, much before any RBF project was started, much before. So I think that he is the man to give us a view of what is going to happen in the next future after this IRB sustained cooperation. So we have an ice cream for it.
Can I say something?
Yes, please. So
So
Emmanuel will anticipate you, then you.
Thank you. As Thomas prepares, I think he had something to say, certainly. One, I think LACHO can be a catalyst, the catalyst for some of this. First, we are available. Next, we are very open to interact with Kalongo. You don't have to reinvent the wheels. For example, we do have indicators that we have already been using, and I think this we can provide. Even to support in verification, this we can do. The other thing is that also to say to the University of Napoli that we are available. I think we do have a lot of that. There are many questions. You ask questions about control groups. We have units where there were, for example, we have not, let's say, virgin units are still there. So you can do pre-post. But we are also opening up and then we are still open to study this, the effects of after the grant, whatever happens, whether we get or not get. So I think we are open, and we, as head of research, I actually am keen to say this. We are looking forward specifically to these research collaborations that we can also contribute, not just to the patients, but also to the knowledge. So we want to pose ourselves as the catalyst, and yeah, and like the younger doctors said, if there are opportunities to build capacity interactively, this we should continue to consider. Just like the pediatrician was in Lacho and learned, if there are any such opportunities and collaborations, we really want to look forward to them. But otherwise, next stop is surgery and theater. I think for us, it is surgical units and theater that do not yet have checklists. The other big area of still challenge is the neonatal, the neonatology. I know there are thoughts around it, and but that is an area that we still want to even bring specific measures of quality for the neonatal. Otherwise, we'll continue to send our hands out and to propose, like the director said, to propose RBF as a possible means of getting funds. And if there is any opportunity, we would like to collaborate with you in writing the grants. Thank you.
Bene, well done. Now let's hear from Thomas. No, conclusion, moment.
I thank you, Donato, for this opportunity, because I also would like to clarify one thing. I think there has been a bit of a misunderstanding in some areas. Some question one question that was posed before said, how do you think you can survive, and how can the incentives survive after the end of the RBF? Now, the way that RBF project in Lachore has been constructed was not dependent on the incentive. Actually, when the New Health from UK came in 2011, they wanted us to disperse the money to the staff in a really managerial way. You get the analysis of the quality, you reward the staff. We said no. The hospital said no. Emmanuel, we were with Dr. Martin, we said this is not the way that our hospital wants to do the things. The RBF needs to support the running cost, and it needs to subsidize the patient. The RBF project have been key to subsidize the patient, not to reward staff. We have later introduced an RBF performance bonus, which is part of our policy even when there will not be RBF any longer. We want to make it sustainable. It's not that the project arrives and then the patients, the staff say, oh, but then the project goes away and we don't get money. And this RBF performance bonus was a fixed one. It's not that we distribute the money that arrives from RBF. It's a very small amount of the salary, because we don't want people to be afraid that if they lose it, they cannot pay their bill. It's it's important that we have this small amount, because it gives a small gratification every quarter, but it's a teamwork. It wants to promote teamwork between the people, among the people. And you don't get it only if the quality score gets very low. So all are confident. The real motivation of RBF is given by the collective effort to do things better and to see them recognized. While RBF as a scheme is great because it helps us to subsidize patients, because it's so difficult to find, as Dominic said, somebody who pays for you the running costs, because the donors so often they want to give us the equipment, but if we cannot pay the people that use this equipment, if we don't pay the drugs, what can we use the equipment for? I'm not underestimating the importance of the equipment, but this is what RBF was great. It helped us to get funds and to attract funds for what we need most, to pay these wonderful clinical staff that treat day-to-day our patients, to pay for the drugs, to pay for these things that often it's so difficult to get, and to do it by asking, by highly subsidize the patient. Our patient pays at token fees the most vulnerable ones, and that we can do only because projects like RBF support the running costs. And the quality, the quality comes from this sense of teamwork, sense of belonging, sense of purpose. I mean, people like Dr. Emmanuel, Dr. Venice, and the Calongo, they work because they want to see that their community get better, not because they want a small reward or incentive. This is degrading, I think, for them. That doesn't mean that a small reward is not necessary and it's not good. So this is my
answer. Stay there, because I want just one personal question. Yes. One personal question, then we have my colleague here. Un momento. In Italy, we still have a lot of health contracts, especially the dirigenti, top class, in which a third or some part of the salary is objective based. So the director sets objective, and then if you get the objective, so in many parts, because of unions, everybody gets 100%. But if these things works, what do you think about single incentive on salary for reaching objectives? Like,
I don't think I'm the best person to do. I worked in PricewaterhouseCoopers. We had a performance bonus, and it was given to everybody.
Yes.
And we worked in the public administration. It was given to everybody. And in a way, I think it's okay. I don't believe in rewards. It's so difficult to reward the single performance. What we do in LaChore is to ensure that when we do promotion, we promote people that are performing well. We don't want the other people to see that poor performance get promotions. But that's a long time evaluation in which our managers, Dr. Martin, Dr. Emmanuel, when he's in the committee, they assess over a long run that a person is fitted to lead. This is the way we reward performance, not with the carrot and stick every month in which you try and hope to identify in this management obsession, sorry.
It's okay.
I come from Bocconi, and in Bocconi we studied these things. I don't believe in them, sorry.
Okay. Thank you. We have a question from here. Please. Microphone.
Well,
yes. It's working.
Mine is not a question. Rather to contribute to this discussion. One is, it is true that we might have to make some changes, like Livia was saying, that you include certain areas to be assessed. The only comment, however, is we have to keep it as less complex as possible.
Yes.
If we make it so complex, it becomes difficult during verification, and therefore difficult to score. Now, my other contribution I want to make to this discussion is that for the two hospitals, we have already seen that there are certain areas that have always been performing very well. To some extent, we are already seeing that, especially for LaChore, the performance is now high, and high. In RBF sense, this calls for another review. Is this high performance really high? Is it that the system has already arrived to a certain level that certain things are already normal to do? Does it mean that you ask yourself, is it really true that this high performance is real high? So in this area also, we need to review. Are the things we are scoring still relevant even now? Some things may not be relevant as you move along the
journey of RBF. So we propose that where you already have very good performance, it calls for review, and you might want to adjust to sustain the momentum. Thank you very much.
Okay, well, thanks so much. Please.
This is just my thinking. I hope it helps us change our mindset. In both hospitals, Kalongo and Lacho, what we are seeing, we are making comments that RBF is bringing probably an increment in maybe somebody's earnings and so on and so forth. But the question that I want to ask all of us today is, if really it's true that the RBF is bringing maybe an increment in somebody's earnings personally, why is it that we still have a high turnover rate? Does it really make sense to us? I think it calls for deeper understanding of what exactly is going on, and it may eventually come to a point we may have to get a different name for this kind of mechanism. It may not necessarily be results-based financing. It may have a different name. I don't know. It's just a food for thought for us.
Thanks. Oh, what intelligent thought. Very good. Well, I think even if we are before the time, I think we have enough discussion today. I have my own proposal. I mean, normally when a project goes to an end, but we understand that RBF is not going to be stopped in both Kalongo as well as Lashore Hospital, but we were given a beautiful present today, a book, plastic printed, with all the results of RBF. But why we cannot see those same people writing a sort of a manual how to make a good RBF project? Because now, again, I think that these experiences should go behind the two hospitals. It should be enlarged and become available. And what are the dissemination tools we know? Of course, this is a dissemination tool, a meeting. Then the leaflet is a dissemination tool. That's another thing. Then scientific publication is a dissemination tool. But also we have things like this, a guideline, a book, a manual, that is a dissemination tool. So I think that that could be a good proposal not to miss those results and going to something that can be readable in the next future and usable by other enthusiasts like these people from Lashore and from Kalongo. Well, thanks very much for this supporting myself in this short round table. If there are no more questions, I leave the microphone to my twin.
Just to say that we were really impressed by your contribution, and I just wish you to meet again at 8:15 to the pizzeria Il Pomodorino in front of the road. And before you leave, the mayor of Naples will leave you with a small gift, so you slowly get out. Arrivederci.